I wouldn't have lost out of my briefing also.
I am being
Shall I start the
the
presentation
teacher.
now?
I am being informed just now at 3:48 precisely. I am being told with that candidate for last 3 days I was with her.
Anyway, it's okay. Now I'm going to give a 0. I cannot
Hey,
do anything.
fine,
Yeah.
fine, fine. Yes, please.
Yeah, you can go ahead. Sukini, it's your presentation now?
Yes, ma'am.
Yeah. Please go ahead.
So good afternoon, everyone. My name is Dr. Sukini and my guide is Dr. Vidya Bhatt ma'am. And my topic is about role of endoscopy in infertility management. So coming to the patient details, a 30-year-old Miss X of occupation housewife residing in Bangalore of low upper middle class socioeconomic status came with a chief complaint of anxious to conceive and complaints of intermenstrual bleeding since 5 years. But her menstrual history, age of menarche is attained at 13 years of age. Cycles were regular with intermenstrual bleeding of 3 to 5 days of flow, with 25 to 28 days of cycles, soakage of 3 to 4 pads per day, not associated with any dysmenorrhea. Obstetric history, married life since 5 years, non-consanguineous marriage, and she has history of 1 abortion, spontaneous at 7 weeks of gestation, for which suction evacuation was done 2 years ago. Coital history, coital frequency was 2 to 3 times per week, and aware about the fertile period, and no history of any usage contraceptives or dyspareunia, post-coital bleeding or erectile dysfunction. And coming to the medical history, there is no history of any diabetes mellitus, hypertension, thyroid diseases, heart diseases, tuberculosis, or asthma. Personal history, she has non-vegetarian diet with bowel and bladder habits are normal. Sleep and appetite was normal, and no history of any smoking or alcohol intake. Coming to the family history, no history of any diabetes, mellitus, or hypertension. Any chronic illness was not there, and no history of any previous surgeries. Coming to the history of male partner, of age 32 years, Mr. X, occupation of business, no complaint of any erectile or ejaculatory dysfunction, no history of any medical or surgical comorbidities or alcohol intake and smoking. Coming to the general physical examination of the female partner, she is moderately built, nourished, conscious, cooperative, and well-oriented, with mild pallor, no icterus, cyanosis, clubbing, edema, or lymphadenopathy. BP was 100/60 and pulse rate is 72, BMI was 26. Systemic examination was normal, with breast and thyroid spine is also normal. On parabdomen examination, on inspection, there is no visible scars, sinuses, dilated veins, or any pulsations. On palpation, no local raise of temperature. It is soft and non-tender. Local examination was normal with the normal pubic hair distribution. For speculum examination, the cervix and vagina was healthy, minimal brownish discharge was present, and bimanual examination, uterus is bulky with bilateral fornices free and non-tender. Male partner physical examination, moderate, he is moderately built and nourished with BP was normal, pulse 80, BMI was 24, systemic examination, thyroid breast examination was normal, no signs of any gynecomastia present. Coming to the investigations of female partner, HB is 10 and all other investigations are normal. FBS, PBS, thyroid function test was within normal limits. FSH, LH, prolactin levels were normal. Serum AMH level is 2.8. Serology was negative. On scan, vaginal ultrasound, uterus was 10 into 7 into 6 centimeters, showed presence of 2 into 3 centimeters submucosal fibroid in the posterior wall, and endometrial thickness is 6.4 mm. Right and left ovary volume and size was normal. Coming to the MRI pelvis, the uterus showed the presence of 2 into 3 centimeter nodular lesion in the posterior with T2 hypointensity suggestive of leiomyomatosis, and the myomata is present into the uterine cavity into myometrium, resulting in the distortion of the endometrial lining. Male partner serology was negative. Semen analysis showed normal study. So the diagnosis is secondary infertility with uterine leiomyomatosis with FIGO staging 1 to 2. So for this patient, an initial
Before we go to the management, what all you
Yes.
missed during your examination findings? There are many things which you didn't tell me about.
examination, general physical examination, and then vitals, ma'am.
But you didn't,
Examination.
you've not told me about whether the patient has hirsutism or not. You didn't tell me anything about acne, about galactoria. Then your ultrasound, most important finding is you have not told anything about the antral follicular count. The volume is so less. So then if you're going to go for surgery, if the volume is less, if the antral follicular count is less,
Count is less.
then probably
Because we had to treat
IVF
that.
thing
and
of
then-
embryos and then transfer, then doing a surgery and then transferring would be a better option. Because
Yes.
the volume is 3 ml. 3 ml is a very small volume for the patient. So that's the most important things you missed over here.
Yes, ma'am.
Because I think all these are very, very important. Now you go with the management.
Coming to the management, initial diagnostic hysteroscopy was performed by hysteroscopic myomectomy of FIGO stage grade 1 to 2 submucosal myoma using a monopolar colon knife and then tissue retrieval system. And then the procedure with normal saline as a distension media, the uterine cavity size, exact location of the myoma was inspected, and then diluted pitracin with 10 units in 100 ml of normal saline is diluted, which is injected into the endometrium and pseudo capsule. The media is then changed with the glycine, and an incision was made with monopolar Colin's knife on the serosa overlying the leiomyoma until it reaches the capsule, and then myoma is shelled out. By using hysteroscopic tissue retrieval system, the myoma is removed from the uterine cavity, and the whole procedure lasted about 20 to 25 minutes. There was no excessive bleeding nor fluid overload in the post-procedure. She had given 1 cycle of oral pill or OC pills to promote the endometrial regeneration.
So why do you give OC pills to promote the regeneration? I don't think a OC pill is given na, to.
Estrogen.
So you should give a high dose of estrogen and.
Estrogen. Yes.
Yeah, but then why you've written OC pills? You've written OC pills.
Sorry, ma'am.
Pills are
Adu
not
estrogen
given.
high dose.
So what estrogen have you given? If you're saying you've given estrogen, what estrogen have you given?
One.
Which estrogen you have given? I'll just finish this and take before my podcast after recording. I have.
Ma'am, sorry, like
No. Which estrogen did you give now? If you're saying, okay, you said oral contraceptive first. When I said you have to give estrogen, you said you're given estrogen. So which estrogen have you given?
high dose estrogen was given, ma'am.
There's a name to the estrogen, which is normally given after any resection. So what was the estrogen? What is the name of the estrogen? You've done your MD now, so if you don't know even that, then what's the use? So you don't know what is given. If you don't know what is given, how are you going to treat the patient? Because the estrogen in your oral contraceptive is not enough for the regeneration. That's just 30 micrograms of oral estrogen what you have. Go ahead. Find out what has to be given and then send me a message.
Yes, ma'am. Video, ma'am. The uterine cavity and the ostia, everything is inspected. And then vasopressin is injected.
But I couldn't see a bulge into the cavity, na? If it is a submucous, there has to be a bulge, na, into the cavity. So it must be a intramural myoma. I can't see a bulge over here.
Is there, ma'am, this one? Monopolar, we are resecting, ma'am. The incision is being given, ma'am.
Yeah, but I don't know. It's not very clear. Okay.
The myoma is seen on there. Then with the tissue retrieval system, we have removed, ma'am, completely.
So what do you plan after this for the patient?
So some ma'am, after 3 months, 3 months of follow-up, an ultrasound showed a uniform endometrium, for which the patient was given ovulation induction and she conceived, ma'am, with 5 weeks of 2 days of gestation.
So if she wouldn't have conceived, what do you consider? And for how long have you waited after the resection for giving her treatment?
Ma'am, at least 2-3 months we have to wait, ma'am,
Huh?
for the endometrial regeneration.
Hmm.
At least we have to wait for 3 months before
You have
starting
not given
for
her
her
only
to
anything.
conceive.
You don't know only anything what has to be given. You're not given her anything for regeneration. You don't know only what dose of estrogen has to
Ma'am,
be.
by the height.
So no, this is not the, when you're presenting a case, everything should be known, not to you. How can you present a case without knowing what is being given to the patient? Nobody is going to come and manage for you now once you go out and you start practice. I don't think your Dr. Vidya Bhatt is going to come and manage the patient, or I'm going to come and tell you what has to be done for the patient.
The estradiol is given, ma'am, around
What is the
Six-
dose and what
6
estrogen is being
6
used?
mg, ma'am. 6
Huh?
6 mg, ma'am.
No. So what was the antral follicular count? That also you don't know. So at least you've not written, at least tell me what was the antral follicular count. And how would you manage her for infertility after 3 months? You have not checked her tubes. She's had one abortion. So would you not like to check her?
Previous history of HSG was done, ma'am, already. It was normal only, ma'am. Previously it was done.
Yeah, but you didn't show me the picture of HSG. So I would have known if really the myoma was projecting or not. Because the myoma was too small. It was hardly 2 centimeters. So if it is not projecting, it's best not to touch the endometrium, because any monopolar cautery on the endometrium is going to decrease the receptivity of the endometrium. So I don't think you told me also that the HSG is normal. Otherwise, I wouldn't have asked the questions, because I write down everything, whatever you're telling me, okay?
So after the procedure, 2 to 3 months of endometrial regeneration, after that she can be started with ovulation induction drugs, and then we will proceed, ma'am. Started with letrozole, 2.5
So your
mg, ma'am,
ovulation
from day
induction,
to
but why you given letrozole?
day, 5
Letrozole
days.
is the first line of treatment only in patients with PCOS. It is not the first line of treatment in any other patient. So why have you given letrozole?
Yes.
Why have you given letrozole? You tell.
Ma'am, in our hospital,
She's not PCOS, na? Her AMH value is
first
just
line of
2.8
not
and her
PCOS.
ovarian volume is 3. So she's not PCOS for sure. So why is letrozole been given? Letrozole is not first line of treatment for a non-PCOS patient.
Yes, ma'am.
On
Clomiphene
what
citrate is a
basis have you
first line of
given letrozole?
management.
Pardon?
Ma'am, the
I can't-
clomiphene citrate is a first line of management, ma'am. But we practice letrozole, ma'am, here.
How can you practice anything? Na? You are talking in a forum. So you should talk what is evidence-based. What you do in your practice is, and with your patients is totally different. So the
First
first
line of management is clomiphene citrate, ma'am. Clomiphene citrate is the first line of management. We will start with 50 mg from day 2 to day 3, ma'am.
this woman where the 50 mg is going to go, her BMI is 26. Where the 50 mg will go?
We'll start, ma'am, once the ovulation is confirmed, we can stabilize in that 3 to 6 cycles. Otherwise, we will increase on doses, ma'am. Maximum
What?
dose till 250.
What?
Ma'am, we will start with the minimal dose. Once ovulation is there, then we will continue with that dose. Otherwise, we will increase the dose, ma'am. Maximum till 200 to 250 dose we will increase.
I don't think the dose of clomiphene citrate is 200 or 250.
No,
The
ma'am, minimum. Ma'am, that is the
maximum dose is
maximum dose.
150 milligrams, not 250 milligrams. She doesn't respond to 150 milligrams. What would you do?
Then we will go to the next one, that is letrozole or gonadotropins, ma'am.
So how would you give gonadotropins in this patient?
Ma'am, gonadotropins we can give HCG.
Huh? What?
The minimum dose, ma'am, from continuous every day we will start, ma'am.
I can't understand what you're talking, okay? What you said, I didn't understand. What you said, tell me. I didn't understand what you said. How would you give the gonadotropins? What are the other indications for endoscopy in a patient with infertility?
Another is more than 25 years old with 3 years of unprotected coitus, not conceived or
What is
unexplained
the
infertility.
indication for endoscopic surgery in a case of infertility? I'm asking a general question. I'm not asking about your patient. This is a general question. What are the indications I'm asking?
Recurrent pregnancy loss, unexplained infertility.
You need to, my dear, divide it into laparoscopy, you can divide it into hysteroscopy, then you talk about the indications for hysteroscopy, then because both are endoscopies. You cannot just give a arbitrary answer of recurrent pregnancy loss or something like that.
Ma'am, laparoscopic.
What are the indications for hysteroscopy? What are the indications for laparoscopy?
Ma'am, indications of hysteroscopic myoma or any proximal tube block, any Mullerian anomalies or Asherman syndrome.
What Mullerian anomalies for everything you're going to do?
No,
Are you
ma'am.
going to do unification of
Bicoordinate
the
or
uterus? You're going to do
septate.
unicornate, bicornate, everything? What is the indication?
Bicoordinate uterus or the
Bicornate
septate
uterus. Are
uterus,
you going
ma'am.
to operate the vagina?
Septate.
I think you should read and come now. How can you pass like that when you don't know only what has to
Ma'am,
be done
septate.
for your
Ma'am,
case?
septate, ma'am.
Okay, further.
Ma'am, septate uterus, ma'am. And then laparoscopic indications can be for recurrent pregnancy loss or any adhesions, myoma.
Is recurrent
And
pregnancy
you-
loss an indication for a laparoscopy? Why is it? You give me an answer. You give me a reasonable answer why it is, then I will accept it. Why is a laparoscopy necessary for recurrent pregnancy loss? Today, hysteroscopy, and there's no role of diagnostic hysteroscopy.
Ma'am, how is this?
Where there is a 3D ultrasound, everything can be identified. So basically, and according to the several trials which are there, there's a, the trials which are there is no indication that it's really going to help. So what are the other indications?
Any for doing any tubo-ovarian lysis
Huh?
or canalization, tubal canalization, endometriosis.
Hmm.
Or any PCOS cases, ma'am.
PCOS. Nowadays, do you do drilling? What's the evidence for doing drilling? What's the
Ma'am, for PCOS, first treatment will be lifestyle modifications,
What
ma'am.
is, I'm just asking you, what is the evidence for drilling? I don't want to know the other managements. I'm just asking you, what is the thing for drilling?
Because of
What's the indication? In which cases you're going to do drilling?
moderate volume is there, then we will go for drilling, ma'am.
What? What are the other indications?
For hydrosalpinx or any distal tube blockage, ma'am.
So what are you going to do for the tube blockage?
If it is distal tube blockage, we can do salpingostomy, ma'am.
What
For
are the
mild cases of
what are the results of salpingostomy? What are the pregnancy rates after salpingostomy?
pregnancy rates are less only, ma'am. Or we can do salpingectomy and then followed by IVF, ma'am. if it is for severe hydrosalpinx. And if the distal fimbrial is blocked, then we can go for neosalpingostomy fimbrioplasty, ma'am.
So what are the pregnancy rates after each procedure?
Read and tell, ma'am.
Nilima, you'll tell Vidya Bhatt to join kya?
Yes, ma'am.
Any questions you all can ask me? Because I have a webinar now to join. So till Dr. Vidya Bhatt comes, if you all have any questions, you all ask me and I will answer them. Today, PCOS drilling is only beneficial in lean PCOS who have a elevated LH and androstenedione levels. Usually, CC resistance, what we use is gonadotrophins. Today, there's no role of ovarian drilling because the medical treatment is much better than the surgical treatment, because ovarian drilling can reduce the ovarian reserve as well as it can also result in adhesions and therefore increase the infertility. For man-ovulatory, it will again become a pelvic factor where you could have where you could have adhesions, and secondly, there could be decrease in the ovarian reserve. And therefore, as far as possible, drilling should not be done. Probably in smaller places where the patient cannot come for regular monitoring, then one could go and do, one can do drilling. Otherwise, there's no indication for drilling today. Hello. Yeah, so today for distal tubal block, usually what happens is if you do a surgery, initially when IVF was not available, that was the only method and so it was used. Hello. हा ते डिलिव्हरी आली आहे तो माणूस खालती उभा आहे बघ ते 11 बॉक्सेस आलेत हो 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 नाही नाही त्यांनी मला फोन केला ना म्हणून म्हंटल तुला मी तुला त्याचा नंबर देते तू फोन कर ठीक आहे हा
Hello, ma'am.
हा Yeah.
Ma'am, called Vidya, ma'am, and she is in surgery, and she will join at 5:10, ma'am.
And ask otherwise Vasan now, let him then finish his talk.
Okay, ma'am. Okay.
You have his number?
Yes, ma'am.
Yeah, so basically then it is better to go for IVF than to go for tubal surgery. And if it's hydrosalpinx, there's usually loss of the ciliary processes which are there, and therefore it's best to do a salpingectomy, or you can just do disconnection of the tube. Many a times it's engulfed in adhesions, and if you cannot separate the tube, you can just disconnect the tube at the cornual end. Usually what we use for regeneration of the endometrium is Primarin, where it is given in the dose of 1.25 milligram twice a day for 25 days. And in the last 10 days, we should add progesterone in the form of medroxyprogesterone in the dose of 10 milligram twice a day. When you're doing when you have a submucous myoma, it depends whether it's projecting into the cavity or not. So a 3D scan is very, very important. If it is not projecting in the cavity, it is best to leave an intramural myoma as it is and not do it. But if it is projecting into the cavity, then it is best to remove it. You can give estradiol valerate also, but conjugated estrogen is a better drug for endometrial regeneration rather than estradiol valerate. Basically, now that Elagolix basically is used in patients with endometriosis, and its role still in other things is still being investigated. And therefore, unless we really have a lot of studies on that, we really cannot tell for what other indication it can be used. Now it is basically marketed more for endometriosis. You can just put the questions. I'll just come in 5 minutes. I'll just see one patient. You can ask any other question, any other topic also, it's fine. So if you're very confident of a saline salpingography, where you do a transvaginal scan and you're sure that you can see the fluid, because you normally cannot see the fluid flowing through unless you put a Doppler where you know that it is flowing. And then, and basically what you infer, many of the people infer, is by just seeing fluid in the pouch. So that does not really make a sense unless you're using a Doppler when you're doing a saline salpingography. So if you're very, very pertinent of what you're seeing, then that is a better procedure. And it's more better to do a HiCoSy because that has 100% sensitivity and specificity, whereas SSG does not have that much of a sensitivity and specificity. So then HSG is better, but where you can document what you're seeing. And especially if you do it under C-arm, where you take multiple images, so you can make out each part of the tube, which is almost equivalent to that of a laparoscope.
Patil ma'am,
Huh?
ma'am, Vasan sir is committed to some other work. He will join at 6 p.m.
Okay.
Thank you.
So whatever time, then we'll wait. If they have any questions, they can ask me. So depending upon what the tubal pathology is, if there's only a proximal block, you can do a hysteroscopic cannulation, or you can do a cannulation when you're doing an HSG. And basically, that's the only thing. Whereas other tubal conditions, whatever surgery you do, the chances of pregnancy is less, and therefore going for IVF is a better option. But if it's only a tubal ligation which has been done, and if you have a enough length post surgery, then a tubal anastomosis can be done. So basically, there's no role of diagnostic hysteroscopy unless there is a pathology. So unless you're going to do an operative laparoscopy or a hysteroscopy, there is no role of diagnostic hysteroscopy as well as laparoscopy. So unless you have identified a pathology when you're examining the patient or when you have done an ultrasound examination, then you have to go for an operative procedure. But as long as there's no other pathology detected, and HSG is the first line of test for your tubes. Intralipid really does not have any evidence to be used in patients with recurrent implantation failure. If it is a laparoscopic myomectomy, then it's best to wait for 6 months to avoid any complications during pregnancy before the patient goes for any treatment. Again, the role of growth hormone and IVF is very controversial as well as debatable. There are some studies which say that probably a growth hormone helps in increasing the number of oocytes. But the network study, which was published in 2022, has shown that growth hormone does not increase the clinical pregnancy rate or the live birth rate, but it reduces the dose of the gonadotrophins that are used, and probably there could be 1 or 2 extra oocytes that you would get when you have stimulated the patient. There was a paper by Chidi from Taiwan, wherein he used growth hormone only for about 5 days in the initial part of stimulation. And what he concluded in that paper of his is that he has observed an increase in the implantation rate with the growth hormone being used for 5 to 6 days. But there's no other studies or randomized control trials on that. So that was just one cohort study which was published, but with that we cannot say that it really helps in improving the implantation rates. But if you look at the Cochrane evidence, and there was another paper which was published in 2018, which said that there is no difference again in the pregnancy rates, whether you use growth hormone or not in patients with decreased ovarian reserve. Basically, it's used only in those patients. And moreover, it is going to increase your cost tremendously, because normally you should use about 8 to 12 international units from day 2 of your stimulation till you give HCG. What is post-endometrial transfer? I don't know what is endometrial transfer. So basically, there's a whole lecture which is going to be there on unexplained infertility, because basically, if you investigate the patient properly, you're going to identify all the subtle abnormalities that are present. So today, there is nothing as such as unexplained infertility. But as we do not investigate our patients entirely or in totality, we say that probably it is unexplained, because we just look at a few factors and we say that these factors are not there, and therefore it is unexplained. But basically, it is not unexplained. So basically, LH levels are going to be low because you're down regulating the patient. So, so what you're giving HCG is basically going to result in increase in the LH levels, because its molecule is similar to that of LH, and that is going to result in the maturation. But when you're giving a GnRH agonist trigger, then you have to always do your LH levels and the progesterone levels after 12 hours. And the LH level should increase after your trigger to more than 15 international units. Then only you can say that your trigger has been successful. And the progesterone, there also should be a small rise in the progesterone levels, because that's what is the function of LH. So again, double IUI is controversial because there are several studies which have shown that a single IUI done at 36 hours is more than enough. But one must remember that many a times if the follicle is not ruptured, a double IUI may be required. That one is because we are putting the sperms directly into the uterus, and therefore they just go into the tubes and are into the peritoneal cavity. And if the egg is not released at that point of time, then they might be lost and the fertilization will not happen. Because otherwise, in a normal patient where intercourse is done, normally all the sperms are stored in the crypts of the cervix and they are gradually released. So even if you have intercourse 2 days prior, you can still, the egg can still get fertilized even after 48 hours. So this is not so in when you're doing an IUI, and therefore, if the follicle is not ruptured after 36 hours after your trigger, and if it ruptures after 48 hours, then probably there could be a role of a second IUI. But again, as I said, it is controversial because there are many papers which say that a single IUI is enough. Normally, the abstinence before IUI again should be 3 days. And therefore, once the follicle is 17 to 18 millimeters, you must tell the patient to have intercourse or tell the husband to remove the sample. And after that, because that would give us 3 days of abstinence. What endometrial transfer? Is it embryo transfer or endometrial transfer? There are some papers which have said that sequential endometrial transfer can be done, which would probably increase the chances of pregnancy in patients with recurrent implantation failure, where you transfer one embryo on day 3 and you transfer one on day 5. When you're giving a trigger, you have to look both at the follicular size and endometrial thickness. So in a natural cycle, usually a trigger should be given at a follicular size of 22. In an oral ovulation cycle at a size between 20 and 22. And that for a gonadotrophin cycle between 18 to 20 millimeters. The endometrial thickness is the function of the follicular growth and the estrogen, unless the endometrium is injured and therefore does not respond to the estrogens, then basically you'll have a thin endometrium. But if the endometrium is normal, it would correspond to the follicular size and it grows with the growth in the follicles. So basically, today there's no role just for endometrial biopsy. unless you're suspecting some pathology, like you're suspecting infection, tuberculosis, or in patients of PCOS where you have endometrial hyperplasia, where you need to rule out endometrial hyperplasia or endometrial cancer, then only an endometrial biopsy is indicated. Again, role of PRP in endometrium is debatable. It is still an investigational, it's under investigation and it's still under research, and therefore one cannot vouch for it. So whenever you're doing PRP for thin endometrium, you must take a consent from the patient that it is still experimental and that it may not be 100% effective. HCG trigger should be either 5,000 or it should be 250 micrograms of recombinant HCG. So in endometriosis, if the follicles are accessible, it's always better to do a IVF and freeze the embryos, do a surgery and later transfer the embryos. Because when you're doing surgery for endometriomas, there's always removal of the cortical tissue because we know that endometriomas are basically pseudo cysts. So basically it is because of the blood getting accumulated over the surface of the ovary. So when you're removing the cyst wall and then you're cauterizing the base for achieving hemostasis, your cortical tissue is destroyed and therefore your ovarian reserve is significantly going to reduce, and therefore it is better to do the IVF first. Even GCF is an experimental therapy, though you can try it.
Ma'am, Vidya Bhatt ma'am is joining in 5 minutes.
Okay. So basically, it depends upon your unexplained fertility. If her main cause of her unexplained infertility is a low AMH value, and therefore doing an IUI is of no use. And so it's best to go for IVF because it's both diagnostic and therapeutic. It's diagnostic because it's going to tell you about the ovarian, the oocyte quality. It is going to tell you whether the fertilization is happening or not, and also about the embryo quality. So I don't think there's any role of doing an IUI in these patients, because how can you have a good response when the AMH values are low? So you're going to have less number of oocytes itself. And therefore IVF is a better option than IUI because it's both diagnostic. Because this patient is then not a case of unexplained infertility, but she's a case of low ovarian reserve. Seema, you'll take over kya? I have one recording, yeah, podcast. Seema?
Yeah. Huh.
I have a podcast now, so I'll just log out. Okay?
Okay, I'm here.
So you can introduce both of them and then you can also take the question answers because I have the recording just now.
Fine.
Yeah. Okay.
Okay.
Thank you, ma'am.
Yeah.
Thank you. Okay, I'm here.
Seema, go ahead.
Hello. Hello. Were you
I
saying
think better
something?
you'll keep your video off because your connection is slow, I think.
Okay, done.
Yeah, your audio is better now.
Yeah.
श्रेया विद्या मैम को पोस्ट कीजिए। सीमा मैम।
Yes, Nilima.
Yeah, ma'am. Vidya ma'am
Hello.
has joined.
Okay, okay. Hi, Vidya. Good evening. My network is bit unstable, so my camera is off. So, इसमें विटामिन उसका कहाँ चला गया? वो का है तुम लोग? इसको एक बार खा
श्रेया, विद्या मैम को co-host कीजिए. Seema ma'am, Vidya ma'am is there.
Yeah. Pratik speak.
Vidya ma'am, you are muted.
Hi, hello.
Hello ma'am, good evening.
Good evening, everybody. Sorry for the delay. It's directly from the OT. Sorry.
Okay. Seema ma'am. Seema ma'am.
Screen sharing.
Pratik sir. Dr. Pratik sir. Seema ma'am. Okay. Vidya Bhatt ma'am, we request you
hello.
to please.
Huh.
Please
Shall
start
I share my screen?
Hi,
Yes ma'am.
hi, Vidya.
Hi,
Good
Seema.
evening.
Hi.
Nice seeing you. My network is not good, so my camera is off.
Okay. Nothing great. I'm in a OT dress, so no problem.
Same here.
Desktop over there. Just screens, documents. Desktop, Kumari. Just a moment. I do the screen sharing. Desktop. Desktop. Yeah. Just a minute. Yeah. Better, no? Catalytic preservation. Just give me a moment. Sorry, sorry for the delay. Yeah. Is my screen visible?
Yes, ma'am, it's visible. If you can go full screen, please.
Full screen. Okay. ಒಂಚೂರು ಇದೆಲ್ಲ ತೆಗೆದ್ಬಿಡು.
Yeah, perfect.
Zoom on that. Yeah. So shall I start?
Hello.
Yes, please.
Yeah, doc.
Yeah. Yes. Can I start now or
Yes ma'am.
I can go ahead, no? Yeah, thank you so much
Yes,
and
please.
extremely sorry. I was operating some technical difficulties, so I was held up. Evidence-based fertility and enhancing endoscopic surgeries. Thank you so much for giving me this topic because this is something very close to my heart. And I'm sure all of you know about it. I need to specify every time. So we are seeing a lot of infertility these days. That is basically because the trend is increase in infertility because of the focus on career, late marriage, late consultations, and postponing pregnancies. And now people have started even opting for oocyte cryopreservation. No, this heading, you can see the heading, no? I don't know. Screen ತೆಗಿಯಕ್ಕಾಗಲ್ವಾ? Screens ತೆಗಿಯಕ್ಕಾಗಲ್ವಾ? Yeah.
ಬಾಳ್ ಮಿನಿಮೈಸ್ ಮಾಡಕ್ಕಾಗಲ್ಲ.
ಹಾ.
ತಡಿಗ.
ಹಾ. Let me just minimize this because it's coming in the vein of my. No, ಇಲ್ಲ ಇದೇ ಬರ್ತಾ ಇದೆ.
ಅಷ್ಟೇ ಬರೋದು.
ಹಾ.
ತಡಿ.
ಹಾ. ಇದೇನು ಕೇಳಿ ಇಲ್ಲಿ ಇದನ್ನ ಹಿಂಗ್ ಮಾಡ್ತಾರೆ.
Isn't it better there?
No, but it is coming in the slide heading ಕಾಣಿಸಲ್ಲ. ನನ್ಗೇನೆ ಕಾಣಿಸಲ್ಲ.
It has to go somewhere.
I know. At least there, this, it's better. Can you close this? Yeah,
Yeah.
yes. Thank you. So for female fertility factors, when you see you have endocrine disturbances, unexplained infertility, congenital anomalies, then anomalies of the uterus, endometriosis, ovulatory failure, tubal damage, immunological factors, and urogenital infection. So why an eye in the abdomen? Sometimes there is a trend that you should not do laparoscopy, but why an eye in the abdomen? Basically because when the USG tells you there is an endometriotic cyst, which is more than 5 to 6 centimeters, longer years of infertility, then the ovarian reserve is going down. So in them, you may have to put the scope. Myomas, which is impairing fertility, and adenomyosis. Then, of course, genital tuberculosis, suspected COX and PID, uterine anomalies, which will affect fertility. If it is anomalies and there is no problem with fertility, then you needn't have to do anything. But like septum or a rudimentary horn, then you have to correct that. Then subfertility, long years of subfertility, then also maybe you have to do a laparoscopy. What do you mean by surgical procedures that enhance fertility? In the present era, where does this stand? The availability and advances in ART have reduced the need for reproductive surgery as a primary treatment. Yes, we don't do it as a primary treatment, but when it is going to improve the fertility, or when you do this fertility enhancing endoscopic surgery, the patient can go in for spontaneous conception, then is the time you think of tackling this laparoscopically. So when you look at the evidences, one of the earliest and widely accepted implications is performing salpingectomies in IVF, but only when there is hydrosalpinx, when there is infection. Please don't go and knock off all the tubes whichever come in the way. Even if there is a little ampulla looks slightly big, they'll go and cut the tube. Please don't do routinely that. Only if there is a hydrosalpinx, obvious hydrosalpinx, then do it. The role of reproductive surgery extends to further to include management of fibroids, endometriosis, which can increase the chance of the woman conception. Basically, because when there is a fibroid, there are uterine contractions, the uterine cavity is increased, there is abnormal vascularization, and that will abut into the cavity and then cause infertility. So these are some things which you will have to tackle. If you find a fibroid which is subserous or it is less than 2 or 3 centimeters, please don't touch that fibroid. Unless that fibroid is abutting into the endometrial cavity and causing undulation in the endometrium, and then the triple line, that is the endometrial and myometrial junction is completely altered because of this, then consider of removing the fibroids. And in endometriosis, of course, 50% of the patients have infertility. A recent meta-analysis concluded that excising deep endometriotic lesions improves the IVF outcome. Similarly, cystectomy through traction and counter traction was considered to be a gold standard in treatment of endometriomas. However, like with laser vaporization, then you can even do chemical cautery of the uterine cavity with either ethanol, or you can do it with the tetracycline. So these things can also improve fertility, that is, the ovarian reserve is not affected. So the role of minimally invasive surgery is improving and the chances of conception. The results should be promising, and management of fertility should be one of the scenarios when we plan this. So the surgical procedures, how do you classify them? Fertility preserving surgery, enhancing spontaneous conception, and by doing this, your IVF outcome also should be good. So these are the three categories where you plan for fertility enhancing endoscopic surgery. So the goal is to restore the anatomic and functional integrity of the reproductive organ, and proper selection of patient is important for a better outcome. So you can do for uterine anomalies, myomectomy, endometriosis clearance, tubal surgeries, and adenomyomectomy. Uterine malformations, defects in the uterine fusion, bicornuate uterus only if the patient has recurrent abortions, then consider that, or the patient doesn't conceive, because in a bicornuate uterus, what happens most of the time, the pregnancy occurs in one horn, and the patient may land up with preterm labor and abnormal lie than having infertility. But in cases of uterus didelphys, that problem will not occur. But you have a bicornuate uterus with a rudimentary horn, and this is a small cavity. Maybe cavity enhancement can be done, and this rudimentary horn, clipping of the tube and rudimentary horn excision can be done. So this is a unification of a bicornuate uterus. Whenever you have a bicornuate uterus, first thing is differentiation. You differentiate it from a septum, because see, the septum is something which appears as two cavities. It is also called as the owl eye appearance. What you have to do is you look at the angle between the two cavities. If it is obtuse, then it is a bicornuate uterus. But if it is an acute angle between the two, that means both the cavities are close by, and you know that it is a septum. So this is how you differentiate a bicornuate uterus from a septate uterus. So apart from this, you can do your 3D scans, and you can also do your HSG. So these are some of the other diagnoses, and a good sonologist will tell you that how a bicornuate uterus and a septate uterus you can differentiate. And even you doing a transvaginal scan, you can always see that when you do a transvaginal scan, the bicornuate uterus is in the frame of the uterine myometrium, whereas a unicornuate the septate uterus is in the frame of the myometrium, whereas a bicornuate uterus is far away and causing an obtuse ankle. So first thing is, when you put in the laparoscope, identify the two horns, maybe a hysteroscopy you can do. Then there is a septum always between the bladder and the rectum, which you will have to separate. See where there is no rectal and bladder tissue. In such cases, you separate that. Then on the uterus, you make incision. You can either make an incision with monopolar current, which is almost equal to cutting, and put two dilators in the uterine cavity just to guide you to the exact place where it is there. Then once you separate the two cavities, you anterior portion you suture anteriorly, and the posterior portion you suture posteriorly. Allow it to heal for 3 months. Put the patient on estrogen progesterone combination. You can also use barbed sutures now. This was an old video of mine wherein I used Vicryl, but you can use barbed sutures. After 3 months, do a transvaginal scan. If you can see a triple line of the endometrium, the endomyometrial junction, if it is good, then you needn't have to do a hysteroscopy. Otherwise, what you have to do is you have to just do an office hysteroscopy, look for any adhesions, and if the cavity is good, then just go ahead and tell the patient to conceive, or you can do any assisted reproductive techniques. So rudimentary horn, most of the time there is ectopic pregnancy, and it can sometimes happen in the second trimester, and on hysteroscopy, it's a unicornuate uterus. See, whenever there is a unicornuate uterus and you have a very small cavity, you can always do a lateral metroplasty, though there is not much of evidence on this, but we have done a lateral metroplasty and made this cavity triangular, and that has helped in patients to conceive, and we have published this paper, and it is in press in the AGL journal. So this is a case of rudimentary horn, and whenever there is a uterine anomaly, please keep in mind that there will be an ectopic pregnancy. Ectopic pregnancy is one thing. Second thing is endometriosis, the Sampson's theory of endometriosis. And here you can find hydrosalpinx, and then there is a lot of adhesions that is basically because of endometriosis. So you separate all the adhesions and you identify the normal uterine horn. Once you identify the normal uterine horn, for your first aim is to maintain the vascularity. So whatever rudimentary horn excision you are doing, you should maintain the vascularity. So don't go near the uterines. As far as possible, try to excise the rudimentary horn, very superficial, and then even the cavity, you can cauterize it, and then or just do a shaving of the rudimentary horn up to the endometrial cavity and block that tube, and you will get a good outcome of that. See, you can appreciate I'm cauterizing the cavity just to prevent further endometriosis. And then what I'm doing is I'm suturing it, completely obliterating the cavity. So this is something very useful when you do, because you're completely obliterating the cavity, you're maintaining the round ligaments, you're also maintaining the uterine vasculature, and the ovary, you have not compromised the ovary. So that is when you get very good results. Try not to compromise the ovary. See, and don't do a salpingectomy unless and until it is necessary. Just clip the tube and cut it so that you get the vascularity is maintained. Only then you'll start getting good results in your fertility enhancing endoscopic surgeries. In a myomectomy, all of us know when you remove symptomatic fibroids, the results are very good. So what is the problem in a myoma? There is endometrial change, deformed uterine cavity when it is more than 5 centimeters, and vascular changes associated with the myoma. So challenges are when there is a broad ligament myoma, cervical myoma, large myomas, adhesions, and previous surgery. So this is a broad ligament myoma. This I was operating in one of the live workshops. So you see a broad ligament myoma. Whenever you have a broad ligament myoma, the principle is you should try to look at the vascularity. Always remember, when we say broad ligament myoma, in our undergraduate days and even PG days, we were always told about the ureters. Well, the ureter is always lateral. Ureter is a retroperitoneal structure, so it is always lateral. So don't worry about the ureter. All you have to do is just look at the ureter and with the peritoneum over that. You didn't even have to dissect the ureter unless and until it is a cervical myoma. And then see this broad ligament myoma, I've completely shelled it out. Look at it, there is hardly any vascularity. And once you remove that, it is the uterine which is bleeding a little. So what you have to do is just approximate that, take stitches. And here, I'm not compromising the tube. I'm not even going near the tube. I'm not going near the ovary, basically to maintain the vascularity and also to maintain the tube. Not to damage the tube. And see, I have gone very close to the uterus and taken 2 layers. So the wound of the myoma is completely closed, approximated well. And this patient later conceived and delivered. She had a normal conception. So the fertility after myomectomy, if you look at the evidence, hysteroscopic myomectomy is 45%, laparoscopic myomectomy, if it is the cause, then it can go up to, here it is 49% in Denon's study, but Donne's study, sorry, and it is up to 80 to 90% also in some of the studies. So this is multiple myomas. When you have like this, it's a big challenge. When it is up to 28-week size uterus, look at the bowel adhesions. The problem is there is a lot of vascularity. You have to go through multiple incisions, and then also you have to separate the sigmoid colon, which is attached to it. As it grows, the sigmoid colon gets adherent to that. See, going in one incision is the best. Try to go before you plan for surgery, map the fibroids either with your ultrasound. If you are good in ultrasound, you can map it with your own ultrasound skills. But otherwise, ask your sonologist who's good to give you a proper picture and map fibroids picture. Otherwise, you can get an MRI to map your myomas so that you don't leave any myoma. And whatever is causing an issue, you can just remove those. And see, as you go posterior, you'll see another myoma popping up because at one site, you don't see all the myomas. So one after another, you have to go exploring the myomas. And more than that, what will happen is you may lose the myomas. So you ask somebody to count. If it is large myomas, then no issues, you'll have a good count. But if it is very small myomas, you may either have to put it into an endo bag, which is a good idea, or you can just take a thread and with a long needle, you can put it into the abdominal cavity, and one end you can tie it, and the other end you can feed the myomas, and like a chain, you can make a myoma chain. So here you can see that all these myomas are removed. And once you remove with an incision, before you go to the other myoma with the next incision, try to suture that. So once you suture, what happens? The bleeding stops, there is better vision, and also you can even approach the other myomas easily. So here you can see the myomas which were anterior and top of the uterus have separated. Now I can see myomas behind. So once you stop the bleeding, once you achieve good hemostasis in this, then go ahead with the other myomas. There was a round ligament myoma, which I removed, and then posteriorly, we had to remove the myomas. See, I'm making an incision. In such cases, posterior myomas are highly vascular. So removing them is a big challenge. See, there'll be a pool of blood. Once again, you have to do good suctioning. And you may ask me, why didn't you do a uterine artery ligation? Well, first challenge was to reach the uterine artery. And the second thing was we don't have evidence saying that you do uterine artery ligation, you can the fertility outcome. So even temporary ligation can cause some amount of damage to the uterine artery. So as far as possible, unless and until you are doing the myomectomy to save the uterus, try not to ligate the uterine artery. Even temporary ligation, the vascular surgeons say once you put a clip or once you do a tie, the artery is damaged, so there can be problems. So best is to take good hemostasis, sutures, and then do your myomectomy. So the last myoma is being removed here. And then the submucosal myoma with an endometriotic cyst. Well, this was a submucosal myoma. We injected vasopressin. And as we went inside, the problem was exactly how to approach it. So I did approach with the vertical incision, and then I tried to dig the myoma. Well, it was deep inside, so I had to increase my incision. You're always worried whenever you enter the cavity. But when good suturing is mandatory, so you want to call yourself a good endoscopic surgeon, please learn suturing. If you don't learn suturing, then your skill of endoscopy is not up to the mark. You may say, I'll do robotic and all that, but still, for such a small fibroid, robotic may not be applicable, or it'll work out very expensive. So see, you can see me respecting the cavity and approximating the myometrium just above the endometrium. So you take interrupted sutures, so the cavity is maintained. And here I'm using Vicryl, I'm not using barbed sutures. So this is my first layer. After I finish the first layer, I go with the second layer of suturing, that is with the barbed sutures, and it is approximation of the muscles. Once I have approximated the muscles, then I'll go ahead and suture the serosa. That is with the barbed, baseball sutures. Of course, you can use the same barbed sutures. Use a 45 baseball suture, a 45 barbed, which will have good length and you can cover, and it has to be very close. Each incision of yours or each stitch of yours should be less than 0.5 centimeters. Only then you'll get good approximation, no hematoma formation, and allow the patient to rest or not to conceive for 3 months, and then you'll get an excellent outcome. And we have had our own publication. This is laparoscopic myomectomy and its pregnancy outcome in infertile patients. We have got very good results, and you can't even identify the scar, so it is that excellent. In-bag morcellation, of course, now it is the trend. So whenever you have a case of a suspicion, or when you're doing, this was one of my live demonstrations. I'll just show you the myomectomy. This is the myomectomy for an infertile patient we were doing. Sometimes it can come as stump or malignancy. So your antenatal scan should be good. Suppose you're doing for somebody above 40, kindly get an MRI and LDH levels done if it is a large fibroid. Here I'm taking a transverse incision, oblique incision. See, more than transverse. See what happens when you take a transverse incision. If you have to extend the incision, you may have to go near the tubes. But if you take an oblique incision, you can just maneuver it however you want. And you can see that myoma being shelled out well. And then, of course, when you go to the base, there is always bleeding. And then this is the suturing which we are doing for that. And always use 2 needle holders. 3-layer suturings of the myoma, suturing of the myoma bed. And this is the endo bag. See, this is the endo bag, and you keep the print on above. You turn it. There is a mechanism to roll it. You roll. There is an applicator. It has an applicator, and put it inside that applicator. And then you push it into the abdominal cavity. Once you push it inside the abdominal cavity, what happens is the tail has to be as a free end. So the free end is the tail, and the whole bag is into the applicator. Then you slowly, don't take tooth forceps, take a grasper, non-tooth grasper, and pull the myoma bag with the tail end out. The tail end will come through your 10 mm port. So keep the print, the black print on the top, and see to it the bag doesn't roll. If the bag rolls, then your myoma will be in one half, and your the telescope will be in one half, and you will not get a good, you can't morcellate. In-bag morcellation will become a challenge. So the other end of the bag, you bring it out and you close it with an artery forceps once you put the myoma in. And the tail, which is in the abdominal cavity, you can feed it through railroad technique. So what we call it as a railroad technique, that is, see, this is pushed. You push it into the 10 mm port through a railroad technique, that is pushing with the instrument, and then I'm putting the 10 mm port, and then you can see myoma in the bag. What is the advantage? There is no spillage. The small bits are not there. Bowel and omentum getting entangled is not there. Safe. The only disadvantage is you don't have another hand to manipulate the morcellator. So that time you should have manipulate it with your own hand, that is with one hand, because the other hand is not free, and the camera person should help you with the good vision. But these small bits which are all inside the bag will come out. So it is, it's a clean surgery. You need to have to pick and choose, and chances of wandering myomas will be less. So endometriosis, lesions and ablation and excision has to be done. Cystectomy, clearing of deep endometriosis. Presacral neurectomy is not done now. It is deep infiltrating endometriosis which has to be treated. So when you say endometriosis, it is not at one place, it is at multiple areas. Distorted pelvic anatomy, peritoneal inflammation, altered hormonal and cell-mediated function, endocrine and ovarian abnormality, impaired implantation, oocyte and embryo quality is poor, abnormal uterotubal transfer. Look at the endometriosis. This is a very large cyst. This was in a young girl whom I have operated. So first thing is, when you have an endometriotic cyst, you inject vasopressin to get proper planes, and the endometriotic cyst may bleed because it's vascular, there is inflammation, and because of the prostaglandin release. So you have to do a proper suctioning, and then you start cutting the cyst, that is opening up the cyst, and look at the adhesions. There'll be adhesions also, so you'll have to release that. So this is how you tackle the cyst. The ovarian tissue has to be held with the non-traumatic forceps, and the cyst, which is usually thick in endometriosis, you should hold it with tooth forceps and then separate that. And you can see the posterior wall, there are a lot of endometriotic lesions. So you have to cauterize that. There is no deep infiltrating endometriosis. So you can just leave the patient like that. And then later this patient conceived, of course, spontaneous conception she had. So when you do a good surgery in endometriosis, the conception rate is very good, especially in early stages. And look at this. You needn't have to, such a large cyst, you should not leave it open like that. So they'll be bleeding, so don't cauterize that. But hold the cyst with a non-tooth grasper and suture it with your Vicryl, or you can use even undyed Vicryl, rapid Vicryl, that is. And of course, Interseed is a boon. I usually use Interseed whenever we do endometriosis. The results are very promising. So deep infiltrating endometriosis, of course, you have to do ureteric dissection. You have to do, instead of using manipulators from the uterine cavity and perforating the uterus, this method I feel is very good. That is, you take a stitch. This is what is followed now. There is so sure technique, that is, you separate the sigmoid colon, identify the ureters, go and dissect the ureters up to the ureteric tunnel, and if there is any endometriosis there, please release it. And if there is deep infiltrating here also, you can also do a nerve sparing surgery. That is, you go lower to the uterosacrals. Here you can see I'm going above the uterosacrals, but you go lower to that, you can see all the S2, S3 nerves which are dissected, and the nerve sparing surgery is done. Here there is no rectovaginal endometriosis, but deep infiltrating endometriosis up to the ureter. You can see me releasing that in the ovarian fossa, go up to the ureteric tunnel, and then do the cystectomy and come out. So these are some steps which you should follow when you're doing deep infiltrating endometriosis. You can see I'm further going up to the ureteric tunnel and releasing it, just making sure that all the small endometriotic nodules and lesions are separated and excised, so that you put the patient. Now we have started using Elagolix. Post endometriosis clearance, I put the patient on Elagolix 150 mg twice daily, and later maintain it with 150 mg one OD, and the results are promising. So retroperitoneal dissection, well, when you have to do retroperitoneal dissection, it is a big challenge. You should go through the medial aspect. There are different aspects of approaching the ureter. One is the lateral oncological technique. That is, the oncosurgeons go laterally. That is, they go between the infundibulopelvic ligament and round ligament. Here I'm going just below the sacral promontory. See, the tube is here, infundibulopelvic ligament is there. I'm dissecting the ureter. And here there is some amount of deep infiltrating endometriosis, that is rectovaginal. So I'm going laterally, separating the ureter, and then going behind the lesion. This is the lesion, going behind the lesion and separating it. and then excising the rectovaginal nodule and separating it. So this is how you approach in deep infiltrating endometriosis. This is our own publication on endometriosis. Neck cell mass whenever there is a torsion. This is something you can have torsion. And what do you see on ultrasound? It is a whirlpool sign. You have to save the ovary, whatever may be. Sometimes when the fertility is not a concern, when it is really necrotic, then of course, when it is about 1 week and you can't do anything, even then they say that you should try, but if it is necrotic, then you can't do anything. But in such cases, see, once you detort it, there is a cyst, this is a para-ovarian cyst, and you can separate that cyst and see to it that you don't cause damage to the tube, because sometimes when it is necrotic like this, you can't identify the tube. So the whole cyst is separated. But can you just appreciate the tube is becoming pink now? So the normal vascularity gradually comes, and then what you have to do, suppose there is nothing, it's basically because of the long ligaments, then you plicate the infundibulopelvic ligament and the ovarian ligament, and there is something called a bulldog stitch. That is, you take the ovarian ligament in a U pattern and suture it to the round ligament without going into the tube, just into the peritoneum. So this is called as the hot dog stitch. And ovarian torsion, again, this is a case of ovarian torsion where there was a cyst. I think I've shown you. So you have to detort it and then do the cystectomy. Dermoid, something which you always see, the tip of an iceberg, and you can see that Rokitansky's nodule. These are something you identify in a dermoid cyst. So this is a torsion of there was a single torsion here, and then once you remove that, then see what will happen is how you remove the dermoid. Now, sometimes the dermoid is deep, so inject vasopressin, and after you inject vasopressin, you cut the tissue. So you make an incision on the ovary. See here, just they're making an incision on the ovary. This is the one. No, not this one also. Well, yeah, then put it into an endo bag and remove it. That's all. That is the, try not to do spillage. That is the main thing here, I think. Yeah. See, once you remove the cyst like this, then you suture, you make an incision, you suture the opened up ovary, and then you put it into an endo bag and remove the cyst. And you can rupture it and see, here you can see this goes to the endo bag, and there you can rupture and suction it so that there is no spillage. So this is how you do without spillage. So TO-mass, ovarian abscess, suspicion of a rupture, immediate surgery, medical management with broad spectrum antibiotic, and unilateral adnexectomy. Only if fertility should be the concern, never to go and do a hysterectomy. So whenever you see an ovarian abscess, ideal would be to drain it and come out, put the patient on antibiotic, try not to do anything. So there is lot of publications, papers saying that whenever there is an ovarian abscess, option should be exploring the optimal treatment options based on current evidence. So as far as possible, large series of patient in determined to clear pathway, but try to just do aspiration and then come out. A surgical approach of tubo-ovarian abscess laparoscopically is more effective than short-term duration of post-operative antibiotic. Just aspirate and come out, the results are good. So there is a lot of evidence on that. And this is a case of tubo-ovarian abscess with a lot of pain. And she came to me, sorry. And see. So we had to remove that, aspirate it, remove that. And then part of the uterus was compromised. Of course, fertility was not the concern here. So that's why I'll go to the next video. This is, yes. This is PID, with DHL with PID. This lady had undergone a cystectomy in the past. There was a lot of infection and she wanted to conceive. They had done an IVF before, but that had failed. So what we did was we put in a hysteroscope and saw that there was a lot of infection inside the uterine cavity. And once we put in the laparoscope, look at the adhesions. So this was really bad. So we had to release all the adhesions, and both the tubes had to be compromised. One tube, of course, we could manage, but both the tubes were gone. And because of this only, they had done an IVF. So what we did was we completely cleared all the adhesions and bowel adhesions. There was a lot of bleeding, and then we could suture and manage a proper restoring the normal anatomy. Subsequently, this lady conceived after IVF. So every time it is not that just doing IVF patient will conceive. You have to do your laparoscopic surgery so that your IVF results are good. So this is again abdominal cox. We treated her with antitubercular drugs. See, look at the lesions. So after this, what we did was we did IVF for her. She didn't conceive. Then we did a stem cell therapy for her. After the stem cell therapy, she conceived and she is doing well now. So sometimes there is multiple approach should be there for the patient to conceive. So you have to do a lot of jugglery. Then tubal surgeries, of course, hydrosalpinx with fimbrial block. Don't do all this. This was done earlier. This will land up with an ectopic. So please don't do all this. Recanalization, of course, this is one of my favorite surgeries. I just finished a recanalization. Basically, why you have to do a recanalization when the patient wants to conceive is because you are giving her multiple chances for fertility. So inject vasopressin. The results are very good when it is lap ligation. See that the distal end does not have hydrosalpinx, and then do a hysteroscopy before that. And then you cut the tube. See, this is isthmic to ampullary. Partly it is ampullary also. So you have to see where it is from a smaller diameter to a little larger diameter. So first you remove the fibrosed area, which is the lap ligation rings. So you remove that and then refashion all the edges. If you want the proximal end to be a little bigger, just take the scissors and make it a little more larger. That is, make it like a fish mouth. So when you do it like a fish mouth, you get a larger area to take your sutures. Here it is good enough. So once you do that, you push the die. The distal portion, some people put the die. I usually don't put the die. Once I finish, I put the die. Then a proper suctioning is done and bleeding edges. I prefer not to coagulate at all. I take a stay suture. This is the stay suture I take, and normally I use 5-0 undyed Vicryl. Barbed suture also people have started using. They even use Prolene now. Because what they feel is Prolene is a monofilament and the chances of reaction is less. But I'm comfortable with undyed Vicryl, which is good enough. We have got very good results. We have a publication on that also, which is in press, and it will shortly get published. So this is the distal end, and distal end you refashion it and keep it ready. So your sutures have to be inside out. First inside out, and then from the other side also it is inside out. Basically, because once you do inside out, what happens? The knot goes outside. The knot shouldn't come into your approximation. So knot goes outside. People ask me, Vidya, how do you identify? And we do the 3-stitch technique. See, what you have to do is first take the 6 o'clock, keep it over the ovary. The ends, loose ends, keep it over the ovary. Then take the 9 or 3 o'clock position, whichever you are comfortable. So a 9 o'clock position one, keep it on the infundibulopelvic ligament. And the one in the 3 o'clock positions, keep it over the uterus. So you will never miss your threads. And people say that, oh, I get confused. No, you'll never miss. Just keep it close, take it, and then keep it in these different directions and then approximate that. Once you approximate all the ends, then you put your second layer. First, it is mucosa to mucosa, and then it is serosa to serosa. And then all the approximation stitches you put. Once that is done, push your die. Once you complete approximation, push your die, and the die will come out. Some say that don't put the die also, approximation would have occurred. But well, for your satisfaction and your surgical satisfaction, once you do this surgery, it is very promising and you feel it's a gratifying surgery, this is. Because the patient will conceive, and then there is a lot of skill involved. Your suturing techniques have to be very good in this. So once you learn this, then it's like if you can do a tubal recanalization, then no looking back in your suturing. And this was one of my live demonstrations in AGL, IAG National Conference, and you can see, yeah. After we have put everything, I'll show you the die now, because I'm taking the second layer. And then once you finish everything, just ask your assistant to push the die and see, you can see the tube dancing there as the die comes out. See, can you see the die there? Yes, beautiful. That's it. So you're done. And this patient has conceived also. Adenomyomectomy, of course, diffuse adenomyosis, focal, you have adenomyoma, cystic adenomyosis. Pregnancy rates are 46%, decrease in menorrhagia 50%, and relief is 81%. But you should do a proper suturing. 3 to 6 months gap should be there. Do a Doppler, look for the vascularity, repeat hysteroscopy, and if you are doing IVF, do a single embryo transfer. So this is scoring, I think I'll show 4-petal technique. This is the one which is now followed, the 4-petal technique. So what you have to do is, here I've done uterine artery ligation, but routinely that is not necessary. We have given vasopressin. And how do you differentiate between a adenomyoma and a fibroid? Well, when you give vasopressin, there will be no good spread of the vasopressin. Then once you start making an incision, you don't see the myoma. You'll just see the uterine tissue. And then you, even on ultrasound, of course, sometimes what happens, you can't differentiate. That is why you have to have a good sonologist to tell you what is the adenomyoma. See, you keep about 1 centimeter to 0.5 centimeters gap between the serosa and then dig into the adenomyoma. See, you have to take a complete sweep over the lesion and then you remove the lesion. After you remove the lesion, that there is a special technique where you close the adenomyoma. That is, first you take you have to take these box stitches. So from outer to outer, and then the inner incision you will have to approximate like your deep mattress sutures, and then you morcellate the adenomyoma. See, this is how you'll have to suture. Then ACUM, of course, many times you people have seen that ACUM, it usually doesn't cause infertility, but it will cause pain. So just remove that and approximate it with good suturing. See, just approximate it. Once you approximate it and then put the patient on, if you want, you can put GnRH, but now we have started using elagolix. So our journey till now, we have been doing a lot of fertility enhancing endoscopic surgeries, and our results are very good. Ours is an IVF center where we have about 40 to 45% to 50% results. That's, I would always attribute it to the endoscopic surgery. So if you have your IVF center, please have a black belt endoscopic surgeon. So to conclude, fertility enhancing lab surgeries are a great boon in infertility and its management. Results are good provided the surgeon is well skilled, or the skill of the surgeon is excellent. Depending upon the type of lesion, surgery should be planned. Don't do unnecessary surgeries also. That is also very important, because you have to be a wise surgeon. Thank you so much for your kind attention.
Thank you, Dr. Vidya Bhatt. That was an extensive over through all the different kinds of fertility enhancing surgeries that we can have. It's a shame that you didn't have more time to show more videos. We enjoyed watching all of this. Thank you so much for being here with us. And thank you for your support for the ICV Reproductive Medicine Trust in so many years. It's always lovely to have you with us.
Thank you so much, Pratik. It's so nice when you are there, you know, it's nice to hear those kind words from you. Thanks a lot. Well, I would go on and on talking about it, but time is the most important thing. So, well, thanks for the opportunity, and I'm sure my next speaker is waiting. Thanks a lot.
Yeah, Dr.
Any
Vasan is
questions?
here.
Any questions? No questions, no?
There's one question in the chat box regarding advanced therapy with elagolix.
Pardon?
There's one question in the chat box regarding advanced therapy with elagolix. You can type the answer in the chat box itself. You can move on to the next speaker.
Okay, yeah. I will do it. Yeah. Thank you so much. I'll type it. Yeah, thanks.
So we're delighted to welcome our next speaker, Dr. Vasan, who is an andrologist of Samruti. He is going to speak to us on male sexual dysfunction and male infertility. Over to you, sir. Apologies for keeping you waiting.
person charge ಇದೆ
ಹಾ.
ಹೋಗ್ಬಿಡುತ್ತೆ ಮ್ಯಾಮ್ ಎನಿ
Hello.
Yes, sir, please go ahead. You can start.
Yeah, I can't. Your voice was breaking. Is my voice clear?
Yes, sir, your voice is clear.
Yeah, I've been given two topics. I don't know whether I'll be able to finish both, but let me try. Otherwise, I'll stick to one topic at least to explain better. So thank you very much for this invite, and thank you all for listening. I will just talk briefly about male infertility management. And basic male infertility involves finding out the etiopathogenesis, and you have various medical history, which I'm sure many of you are aware of, or most of you are aware of, and some amount of physical examination and a diagnostic workup. Basically, we depend on semen analysis as the primary workup for any infertile male, because semen is produced by the body and probably it can be evaluated, and that is a guide to the fertility status of an individual. It's a screening test. So that, one second. Yeah. So the idea of all this is we want to identify the causative mechanism, and then only you will be able to manage male infertility more effectively. It is not every male infertility is idiopathic. It could be hormonal, it could be genetic factors, it could be his lifestyle, and so on and so forth. So the basic confusion arose because of the WHO 10th manual, which was incidentally the 5th manual, where WHO reported the 5th percentile, which essentially meant for all the gynecologists practicing that anything below the 5th percentile value, which was decided by WHO as infertile, and anything above 5th percentile was considered to be fertile, which was not the case to be. Unfortunately, that was the impression which was given. And basically because, first of all, WHO is interested only in effective contraceptive tool, and consequently they want to define only the lower end of the spectrum. So consequently, there was a lot of debate. Why am I talking about this? Because unless you understand semen analysis, and unless semen analysis is reported properly, semen analysis is like ultrasound or your CT scan or your MRI, where the diagnosis should come from the report. So consequently, 5th centile was considered to be the least possible normality, but most of us interpreted it as anything above that value has to be normal, which was not. And consequently, there was a lot of debate and a lot of criticism of the 5th manual. And then also the 5th manual had gone back to only 3 grades of motility, which was again controversial. So all these errors were removed in the 6th manual, and now we have 4 grades of motility, which I don't want to delve into because that is a classification. And we went into what is called as decision limits instead of the 5th percentile. So there is, and also as you can see, there is no mention of terminology. This oligoasthenoteratospermia is a meaningless terminology, which I don't think we should be using. We should be using terminologies normal, borderline, or pathological. So that is what is the terminology which should be used, because that is what is a normal report of any blood parameter or any parameter which you take in medicine. Nobody reports it as oligoasthenoteratospermia, because oligo can be anything less than 15 million or 1 million. All this is a range. So consequently, you need to have some sort of a grading. So in the 6th manual, if you go deeply into the manual, you will realize that there is a normal concentration, there's a borderline concentration, and there's a pathological concentration. Why it is important, I'll tell you. Similarly, motility has normal, borderline, and pathological. Morphology has normal, borderline, and pathological. So consequently, there are 3 groups now. One, it is not an all or none phenomena where you had the 5th percentile. Anything below 5th percentile is infertile, above 5th percentile is fertile. No, it cannot be like that. So just like serum creatinine 1.4 to 1.6, there's a range. So similarly, we have created a Gaussian range. So consequently, borderline are eligible for therapeutic interventions, and you can take a call on the pathological ones, whether you still want to intervene or you want to suggest other modalities of treatment. So it's very important that this is what you want to understand. And also in the 6th manual, now we have a clear-cut method of identifying. There are primarily 2 abnormalities in the semen. Either it is seminal plasma abnormality or it is the sperm structural abnormality, be it motility, be it in concentration, be it in morphology, and you have to define the degree of abnormality. So if you have this information very clearly categorized, then it becomes very easy to manage a male infertile patient, because you need the report to tell you whether there's a seminal plasma abnormality, sperm abnormality, or degree of abnormality. Now that is the most important. Then you can have a precise detailed breakdown of the semen parameter values. So we have made from a reference 5th percentile value to a decision limit concept, and we now stratify fertility potential as a range, and this helps. So this is what is the sort of busy slide which tells you, wherein you had earlier only the now we have defined the 2.5th percentile as the least fertile population. Below this, the chances of fertility is less than 2.5%. But does it mean that all these people above this range are fertile? No. This is the borderline group and this is the most fertile group. So there is a range which is created, which helps the clinician to decide, especially in a case with no female factor or with a significant female factor, how does he want to plan the management. So we have now a borderline. This is for concentration. This is for motility. This is the yellow bar is the borderline range, and similarly for morphology. So now when you understand what are these boxed items which are shown here, this is the borderline range for a sperm reporting. So anything about 22 is a fertile sperm, anything below 11 is pathological, 11 to 22 is borderline. So similarly in motility, anything less than 35 is pathological, 42 to 55 is borderline, above 55 is fertile. So similarly for normal morphology, anything less than 4 is pathological, 4 to 14 is borderline, above 14 is fertile range. So now consequent to this, if you understand now, I clearly told you that you need a division of the way semen is reported, and it is very critical. Now we have very clearly seminal plasma, which is the macroscopic elements, though it is still microscopic, but grossly you are able to see it much easier. So these are all the plasma elements. It is your volume, it is your liquefaction, fructose, pus cells, and live and dead percentage, agglutination, whatever, cellular debris. So all these are separated out from the sperm characteristics. So there is a clear division of the seminal plasma abnormalities on top, and then you have the sperm abnormalities. And then what happens is it becomes very easy. Seminal fluid abnormality, whether there is anything or not, you report it as none. If there is pus cells, you report it as pus cells present. If there is RBC, you report it as RBC present. If there is a liquefaction problem, you report it. If there's a low volume, you report it here. Similarly, this of course was a azoospermic sample, so it is all pathological. Why is it important? Because in the management of any male infertility, the first goal is to treat seminal plasma abnormalities, not the sperm abnormalities. Because many a times it is the seminal plasma which is the carrier medium for the sperm, and consequently treating the seminal plasma abnormalities first many a times will normalize the sperm characteristics. So what are the principal abnormalities of the seminal plasma? You have a volume abnormality, you have a pus cells, you have bacteria, you have RBC, and specifically in case of azoospermia, you might want to check fructose. So these are the abnormalities. Of course, you need to QC the report that there is a 48 hours abstinence, there's no jelly or anything which is used, which might have contaminated the sample, there's no spillage, blah, blah, whatever it is. Once the seminal plasma is treated, then you go to the sperm abnormalities. That I will get back to you how. So I think I'll just give me 1 minute. I just have to switch this slide. Are you still listening to me? Hello?
Yes, sir, we are listening to you.
Okay. Just 1 second. Just give me 1 minute. There was another slide I made, but I think I opened the wrong presentation. I'm just quickly switching that presentation. Yeah. Okay, this is the one. Okay. Are you able to see? No?
Not yet. No, sir.
Okay, 1 minute. I'll just have to link it. Just give me 1 minute. Just 1 second. Just 1 second. Sorry for this. Just give me 1 second. I should be able to sort
No
this out.
worries, sir. Take your time.
See? Is there anything?
Yes, sir, we can see.
Is it the, because I can't see what you're saying. Is it the sperm? Which slide?
Needs to know type of abnormality.
Okay, fine. Yeah, that's the one. So I'm just going to skip the slides, so when you say you want to manage the seminal plasma abnormality, now the critical point is you want to manage seminal plasma abnormalities. What are the things you need? Once you know there is a seminal plasma abnormality, you need to do a physical examination just to check whether there is endocrinologically any problem in terms of testicular development, hypogonadism, or any varicocele, because you want to treat the seminal plasma abnormality first and then treat the sperm abnormality and decide those which are not amenable and suggest them for referral or ART supplementation. So this is what I was just showing you about. This is the normal methods. So here is a case of seminal plasma abnormality of a 30-year-old male with a partner of 27 years, married for 1.5 years. Female factor is nil, and the 5th percentile report. This is the old report. Now I didn't put the decision limit because it will confuse you all. So it just shows that there are pus cells significant, 20 pus cells per however field. So what do you do? So this is the way old report was reported as a 5th percentile value. Now when you we report now, we report here as pus cells, and we just put down here as a diagnosis normal volume ejaculate with genital tract infection. That means we are making the semen report just like an ultrasound report or a CT scan report or an MRI report, where you get a diagnosis, not a diagnosis of oligoasthenoteratospermia, which is meaningless for me. So on the basis of this, now that you know this is a normal volume ejaculate and there is a significant genital tract infection, And what do you do? So the first question most of us have is, oh, there is genital tract infection. Do I need a semen culture? And is it a round cell in the semen? Because sometimes many people confuse round cell with pus cells. That is something which usually is not possible nowadays because of the staining techniques we have. There are several good staining techniques, and I don't think a decently trained lab technician will make that mistake. However, you should bear in mind that sometimes immature germ cells and the other round cells can be confused as leukocytes. Now, the second question is, once you're sure it is leukocytes, what is the cutoff? Do I need to do a culture? Now, we believe that anything more than 4 pus cells in the semen correspondingly represents 10 to the power of 5, which is more than 1 million in terms of the amount of pus cells which will be present in the whole sample. So consequently, anything more than 4, you can treat the patient empirically without having a semen culture. Notoriously, semen has antibacterial properties, and also if you want to do a culture, you have to do both aerobic and anaerobic cultures. And generally, because of the Indian male being uncircumcised, there's a high chance of skin contamination, and consequently, semen cultures are positive only in about 20% of instances. 80% of the time, you will get contaminant, you will get sometimes staph infections, proteus, you can get pseudomonas, you can get all sorts of things, and I have seen people going on treating them multiple times. The only thing you need to bear in mind is sometimes if your infection is not going, India is a country which is known for tuberculosis, and consequently you might want to do a PCR to rule out tuberculosis in certain individuals where there is a persistent infection. Now, having said that, I would not do a semen culture routinely unless there is a persistence of infection after 2 attempts of eradicating the infection with antibiotics of at least 3 weeks duration. So consequently, we would go ahead and treat anybody who has more than 4 pus cells in the semen, and then go ahead. What is the most common cause of the bacteria? Enterobacteria, which is the most common, which is the gram-positive cocci. Chlamydia, uroplasma, mycoplasma are the protozoal infections which can be done. Why does the leukocytes come up? It is because of urethritis, prostatitis, epididymitis. Most of them, as you can see, depending on the suspicion where the infection is coming from, the duration of the antibiotic varies. If it's a urethral infection, it is only 2 weeks. If you suspect a prostatic infection, it is 6 weeks. And if it is epididymal infection, it is 3 weeks. So this you have to bear in mind. So the definition of what is more than 1 million is, like I said, more than 4 pus cells, and we do not need, I have put down here presently more than 4 pus cells is considered clinically significant leukocytospermia, and consequently we go ahead and treat these individuals. So this is the cutoff. I'll just skip. So what is the antibiotic choice? I see most of you prescribing, at least have been lectured to prescribe doxycycline or tetracycline, but I think doxycycline is slowly going out of practice, and at least in this context, it is not a very effective drug. We use either levofloxacin as the first line of drug, azithromycin, erythromycin, ofloxacin, trimethoprim, sulfamethoxazole. I just put down doxycycline because I wanted to highlight the point that doxycycline is no longer the first line of medication used in these cases. We routinely use levofloxacin 500 milligram once a day or twice a day if you suspect some amount of clinical symptoms. There are 2 types of leukocytospermia. One, leukocytospermia where there are no clinical symptoms, where the patient is not experiencing any pain or any pain or burning. Then it is asymptomatic leukocytospermia, or it could be symptomatic leukocytospermia because of affliction of an organ. So you should ask for history of burning urination or pain in the penis or post-ejaculatory burning and epididymal pain or scrotal pain, which is sometimes manifest in these individuals. So the first line is always levofloxacin. If it fails to work, we use erythromycin, and if that fails to work, we use chloramphenicol or trimethoprim and sulfamethoxazole. Added to that, if you are suspecting a prostatic infection, there may be a need to give some prostatic massage and sitz bath. Is there a need to treat GTI and bacteriospermia? Because sometimes not only you find leukocytes, you also find bacteriospermia Do you need to treat bacteriospermia, which is isolated? That means there is no pus cells, but somebody reports bacteria plus, something like that. We believe that there is a need to treat bacteriospermia, especially if you're looking for a conception. Because these bacteria can be transmitted through the ejaculate into the woman, affect the endometrial quality, and consequently either bacteriospermia or leukocytospermia or combined leukocytospermia with bacteriospermia needs to be treated. The next question is seminal plasma correction. Again, these are seminal plasma abnormalities where here there is a volume abnormality. The volume is 1.1 in a 36-year-old male partner with a 34-year-old wife. We're trying for fertility for about 5 years now. And again, female factor is nil, where there's pus cells of 6 and volume is also 1.1. So what we have put down here is volume abnormality plus genital tract infection. And consequently, in this case, the motility appears to be normal, but it can be abnormal. So again, if you go back to our reporting format, which I insist that this is the way, you should also insist on your labs to develop this kind of reporting format, because ultimately you need a diagnosis. You don't need a terminology at the end of the report. So you need a diagnosis, and the job of the laboratory is to give you a diagnosis. You are sending for a test and it should come. If somebody gives you Hounsfield unit on an MRI or a CT, you will be wondering what it is all about, whether it is a cyst, whether it is a tumor. You want to know that. Similarly, if somebody tells you hyperechoic lesion seen on an ultrasound, which is what we used to report long ago, you wouldn't like it, because you want to know whether it's hematoma, whether it is cyst, whether it is fluid, whether it is a solid tumor, and you want a delineation. So similarly, in a semen analysis, we should move to the era where we have sufficient information. The reason why these reports are not given this kind of a structure is no pathologist is interested in reporting. It is left to some technician there to generate this report and just tag it as oligoasthenoteratospermia and give it to you, which is a waste of time, because that is not what you want. You are sending this for evaluation and you are sending for a clinical diagnosis. And semen analysis is a multiparametric report, and consequently the onus is on the laboratory to give you a diagnosis. So in this case, it was a low volume ejaculate with genital tract infection. Now, what is a low volume ejaculate? First of all, you should confirm the volume is low, because it could be because of the fact that the patient has spilled the sample. It could be because of the fact that the patient didn't ejaculate properly, or it could be because of the fact that the patient had not much of abstinence. He had only less than 24 hours. So something was not done. So first and foremost is to confirm exactly that is the low volume. If there is a doubt, you always repeat the sample. Second, in a case of low volume, you always need fructose, because you want to know whether the low volume is because of CBAVD. And in this case, where if there is CBAVD, the fructose will be negative. So it's a very simple diagnosis of understanding whether there's a seminal vesicle present in that individual or not. If seminal vesicle is present, fructose will be positive. If seminal vesicle is absent, fructose will be negative. And that is directly linked to CBAVD. So if you know, if the report comes as fructose positive, then what is your differential diagnosis? Your differential diagnosis is fructose positive retrograde ejaculation, fructose positive hypogonadism, or fructose positive erectile dysfunction. These are the possible differential diagnosis. So retrograde ejaculation, because there are some men with autonomic neuropathy or for various reasons, surgery or other cons, where the bladder neck does not close during an ejaculation and it remains open, and consequently they have retrograde ejaculation. Or it could be hypogonadism because of low testosterone and low LH, and the small size of the testis, the FSH also could be low, and it's hypogonadotropic hypogonadism, and consequent to that, you can have very low output of the semen. It can also happen in very high levels of hypergonadotropic hypogonadism, though it is rare. And similarly, erectile dysfunction. Patient doesn't tell you, but he has significant erectile dysfunction. He masturbates and doesn't reach an orgasm, and consequently he ejaculates very little, and he has a drop of ejaculate which is coming out. So these are your diagnoses. So most important, what I want to highlight is relevance of fructose. Fructose is extremely relevant in a case of azoospermia. In a case of low volume ejaculate, especially if azoospermia. If there is no azoospermia, then fructose may not be relevant, because fructose will define whether it's obstructive versus non-obstructive. So So the reason why, because fructose is secreted by the seminal vesicle, as you can see this arrow, this gland. If it is missing, then there will be no sperm in the ejaculate, and or there will be no fructose in the ejaculate. So fructose negative means it's vasal aplasia or rarely ejaculatory duct obstruction. Fructose positive, azoospermia, we are specifically talking of azoospermia, not oligospermia. It could be primary testicular failure or obstructive azoospermia where the block is at the epididymis, or it could be a vasal block. So, and there again, because of the fact that you have three diagnoses, like I showed you, you could have a retrograde ejaculation, you could have hypogonadism, you have erectile dysfunction. So the best way to manage erectile dysfunction is, we have several PDE5 inhibitors nowadays. If a patient is anxious, you can give him a PDE5 inhibitor and ask him to ejaculate at home and bring the sample. There is also a buffer which we have created which preserves the semen for about 36 hours, so that there is no need to come rushing to the hospital, because most of these men ejaculate in the middle of the night or late night, and consequently are not comfortable bringing the sample, or the sample will not be, the lab will not be open at that time. Hypogonadism can easily be detected by your FSH and LH and testosterone assessment, and you can decide on the treatment. Retrograde ejaculation is, you assess post-ejaculatory urine and check for sperms, and if there is sperms which are not 1 to 2, generally we ask you to count the number of sperm, because this reporting of semen or the urine with 1 to 2, 2 to 3, 4 to 5 sperm is meaningless, because you want to know, because sometimes when a man ejaculates, there is some amount of sperm which stays in the urethra because of the what can I say? It's because of the patency of the urethra and the inelasticity of the urethra. Everything doesn't get discharged. So there will always be some sperm present when you do a post-ejaculatory assessment, but it will never be more than 0.5 million. So you want to know whether the volume of the sperm or the number of sperm in the post-ejaculatory urine, irrespective of whether it's motile or immotile, because most of them will be immotile because of the fact that the urine may kill the sperm because of its acidic nature. You want to know whether there is sperm in the urine and in what concentration it is there, because if it is more than 0.5 million, it is significant retrograde ejaculation, and that requires addressal. What are the treatment options for retrograde ejaculation? We have used several drugs. Very rare to have retrograde ejaculation corrected. Most of us have used ephedrine, which is a very common drug for causing alpha blockage of the bladder neck, but can delay urination, because sometimes initiation of urination can become difficult. Phenylephrine was another drug. Of course, it was available as Sudafed, and I think it is banned now, but you still get phenylephrine. And imipramine, which is again an antipsychotic, but we use in the dosage of 25 milligram BD, and it can help in some individuals, but generally the success rate of treatment, especially if it is a diabetic retrograde ejaculation, is extremely poor. In other causes, or if it is surgical retrograde ejaculation, is extremely poor. In excluding these two situations, if there is a retrograde ejaculation, then possibly you can look at correcting them with medication. Generally, you will know in 3 weeks' time whether medication is effective. If it is not effective, you have to move on to other forms of collecting the sperm and deciding on whether other forms of ART for helping, because not all retrograde ejaculation is correctable. Whereas in case of hypogonadism, you are sure you can correct. What is the treatment of hypogonadism? Generally, hypogonadism means that there is low FSH, low LH, and low testosterone. So first, initiation has to be done to regain the testicular volume, and for that you require LH. So first we start them on HCG, which is in the dose of 5,000 units approximately thrice a week for about 6 weeks. And post that, there would be an increase of 20 to 25% from the existing size of the testis, and it would improve by 25%. At that point, when there is an improvement of at least 20% in the testicular size, then you add HMG. Then it gives you a very good effect. Whether you want to use urinary or recombinant, nowadays the preference is for recombinant, but of course it adds to the cost, and you can use the recombinant FSH. Then you don't require LH. You can stop LH and switch over the patient to recombinant FSH, either in a 150 milligram TID dosage for a month or 2, and then reduce it, down titrate it to 150 milligram BD dosage, bi-weekly dosage for another 2 months. Generally, if it is hypogonadism and the testicular volume improves beyond 6 AC, then the chances of sperm coming out in the ejaculate in 3 to 5 months is almost 90%. But if the volume of the testis does not improve with HCG, or if the volume of the testis intrinsically is less than 6 cc, despite stimulation of about 4 months, then the chances of sperm coming in the ejaculate is extremely poor. So you have to bear this in mind, because there are literature or people profess that they want to give this drug for 18 to 24 months, 2 years. It's a waste of time, because ultimately patient spends a lot of money and there is no rainbow at the end of the sight, and many of times they would have been much happier taking the sperm from the testis and probably going for an IVF than trying to wait for their ejaculate sperm. So my concept has always been, you wait for 3 to 4 months. If you are unable to decide in that, abandon it, go for something else, because that means most likely these are apoptotic testises, where there is, at the cellular level, there is some amount of dysfunction at the membrane receptor level, and consequently they may not be responding to medication treatment. So that, having said that, once the seminal plasma, these are the two primary abnormalities you will see. One is the genital tract infection. Of course, if you see blood cells, then you know you have to evaluate for tuberculosis. And if you see viscosity or anything like that, agglutination, all are related to some form of infection. So I would follow the same path of clearing the infection empirically, even if there's agglutination or viscosity problem. Especially if there is viscosity problem, you look for prolactin, because many a times they're minor prolactin abnormalities. Normally prolactin values are less than 20 in men. Generally you can find up to 50. You don't require to intervene in terms of any further testing. Anything above 50, you need to get an MRI done to rule out a pituitary tumor. But between 20 and 50, if there is, especially above 25, if there is liquefaction problem, then I would give them capgolin for about 6 weeks. Many a times they settle down once a week, 0.5 milligram capgolin. They settle down. If you want to start with 0.25, it is fine, but I would prefer 0.5 milligram capgolin. So that the primary emphasis is correct all the seminal plasma abnormalities first, then decide on the severity of the male factor, because then you will know, once correcting the seminal plasma abnormalities, you will know whether there is still any sperm abnormality in terms of concentration, in terms of motility, in terms of morphology. I just wanted to understand, are you able to hear me? Because sometimes I keep talking, I don't know whether on the other side you're able to hear me.
You sound no problem.
Okay. So once you have done that, the step one is decide on which decision limit. Once we have cleared the seminal plasma abnormalities, then we look at the decision limit. Like I told you, each parameter has a decision limit. It can be pathological, it can be borderline, or it could be normal. So if there is normal, you don't need to treat. So right. So similarly, if it is pathological or borderline, then you go ahead and treat that part. And always bear in mind the severity of the female factor. If a female factor is incorrectable, then there is no point in wasting time on the male factor. So the treatment is always decided by the severity of the female factor, and that is something we always do. Now, before treating sperm abnormalities, you might want to know whether the endocrinologically there is any problem and whether there is any varicocele. These are the only two investigations which may be necessary in cases of pathological, definitely in the case of pathological decision limits or of motility and morphology. Concentration is never important. Don't put your money on the concentration, because concentration goes hand in hand with motility. If motility is good, concentration will be normal. So, and concentration, even if it is abnormal, if motility and morphology is good, patient will conceive. So it doesn't make a difference of concentration. So we are slowly moving away in terms of trying to interpret concentration and using it as a modality for treatment. So I would emphasize on the basis of only motility and morphology. So decide on whether you need an evaluation, either an endocrine evaluation or an ultrasound evaluation, and always have a goal. If I am treating male infertility, my goal is to decide in maximum 8 to 12 weeks whether I'm going to improve this individual or not. It cannot be an endless treatment, go back, come back after 3 months, go back, come back after treatment, because you want to help them have a baby. So now, what is a sperm abnormality? Why does it happen? Now I told you the sperm abnormality is principally what I'm concerned is motility abnormality, morphology abnormality, which is either in the pathological or borderline range. Why does it happen? Why is it not in the good range for everybody? It could be either a pre-testicular cause, which is approximately around 8% of individuals. It could be a post-testicular cause, which could be about 12% of individuals, where there is an epidermal dysfunction, obstructive change of the passage, or infection of the accessory gland. 80% of the time it is testicular. That means there is some spermatogenic defect which prevents proper maturation of the sperm, preventing it to have achieved full motility and morphology. Why does it happen? So this is what it is. So now why do we need to treat it? Because there is always an IVF, right? There is always an ICSI. So consequently, do I need to treat motility abnormality or morphology abnormality at all? We have to realize that upgrading the fertility status improves the chance of a pregnancy in any given modality and also decreases the cost. So if a person is incapable of natural conception because of some problem, if I can upgrade him to an IUI, then it will benefit him because he will at least have a baby. Psychologically, it will be better. So the desirability increases as simpler forms of methods are suggested to a patient, and also it decreases the cost. So a person who is only fit for donor insemination or adoption, if we can offer him surgical sperm retrieval, it's a great help for him because at least he can have a baby with IVF or ICSI. So similarly, a person with surgical sperm retrieval, if we can offer him an ejaculated sperm, then it's a great thing because he avoids surgery. So that's the nature of fertility treatment. Now, medical treatment of male infertility, especially here we are talking not of the plasma abnormalities. I have told you already about the plasma abnormalities. Now we are looking specifically at sperm abnormality. So, and there is specific therapy and empiric therapy, and there is new evidence and management. That's the way I would categorize medical treatment of male infertility. Like I said, we have discussed all this seminal plasma abnormalities. We know what it is. Now I'll go to what we used to consider for time immemorial. All treatment of treatment of male infertility is empiric in nature. Nobody knew what shit we were talking about, and everybody thought there is only empirical treatment. Your guess is as good as mine. Somebody starts him on clomiphene, somebody starts him on HCG, somebody starts him on an antioxidant, somebody starts him on HMG, somebody starts him on a combination. I have seen all sorts of things going around, but there is a science behind it. Now let us understand normal spermatogenesis duration, how long to treat to see a stage, because see a change, because this has changed over a period of time. There was an era when people said spermatogenesis is a 120-day event. Then it became a 90-day event. Now we know spermatogenesis is a 56-day event, out of which 40 days is for spermatogenesis, 14 to 16 days is for spermiogenesis. So it's very characteristic now that it's a 50 to 64 days concept. That means whatever you do, because it's very important to understand this concept, because spermatogenesis in individuals is like oocyte potential of a female. It cannot be modified. I cannot modify spermatogenesis in an individual. I am modifying spermiogenesis. So consequently, spermiogenesis is a 14 to 16-day event. So many of the changes what will happen with your medical treatment should manifest in that individual within 2 to 3 weeks. So no longer you have to wait for 2 months to reassess the semen. You can even reassess at the end of 3 to 4 weeks, and you will be able to decide whether your medication has worked or not. It's a great boon for patients, because otherwise we used to send patients off, go home, take this tablet for 3 months and come back after 3 months. So that doesn't work. Similar to you can't change ovarian reserve. You can't change spermatogenic reserve of any individual. So you're only trying to alter spermiogenesis. So this is what it is. A spermatogenesis is a 15-day event and a spermiogenesis is a 14-day event. Please bear in mind, this is the dictum, this is the norm which will revolutionize male fertility treatment. So now coming to why is it empiric therapy? Who decided it is empiric therapy? Because we didn't understand the endocrinology of the male fertility. We have only 2 cells inside the testis, You have primarily Sertoli cell, you have Leydig cell, and of course you have supporting cells. But at the end of the day, these are the two primary cells. We know that FSH acts on the Sertoli cell, Leydig acts on the LH acts on the Leydig cell, and you have testosterone, which in turn acts on the Sertoli cell. And of course, you have the pituitary axis and the negative feedback mechanism. Now, this is the rather busy slide of how this pans out in a male individual, because the whole treatment of male infertility is purely endocrinological. If you understand endocrinology, you will be able to manage male infertility precisely without even blinking an eye as to what drug should be given, and there's a science to giving the drug. So we all know that. I don't want to get into that in a 1 hour lecture. I can't. In a supposed to be a half an hour lecture, I'll not be able to take male sexual dysfunction, but I will at least stick to this, where I will at least tell you what it is all about from my point of view. So this is a rather busy slide which shows the complex mechanism of male infertility. But to simplify, I'm going to explain to you what is called amplitude and receptor manipulation. Now, we have two cells inside the testis, primary cells, which is the Sertoli cell and the Leydig cell. Now, obviously in a case where there is motility abnormality which is pathological, or morphology abnormality which is pathological, why is it so? Is it because of some receptor unresponsiveness in the cell, or is it because of damage, or is it because of blockage, or is it receptor polymorphism, or is the receptor apoptosis, or is it specifically Leydig cell dysfunction? So what I'm trying to tell you is very, very important. That means there are men with normal cell but having lesser capacity to get stimulated, and this is not sensed by the brain. Normally brain is able to sense any organ going into what can I say, pathological mode. And this is the concept on which your GTT has evolved, your cholesterol challenge test or cortisol challenge test has evolved, where you give a challenge to see whether the cell will respond, right? So GTT is the same concept. We challenge the cell and try to see whether it will respond. So the concept is, what is an amplitude and a receptor manipulation? Same level. That means FSH and LH are the two primary hormones which act on the Sertoli cell and Leydig cell. In an individual A, there are two individuals. Let's assume there are two individuals, A and B. FSH in this individual, which acts on the Sertoli cell, is able to produce normal spermatogenesis. FSH in this given individual B is unable to produce normal spermatogenesis. Why? Basically because this fellow, my individual B cell, may have receptor unresponsiveness, damage, blockade, polymorphism, whatever it is. Now, what do you do with this individual B? Here we don't have to do anything because his cell is responding. It is like a pinch response. I pinch somebody and he feels acute sharp pain and hits me back. Another fellow I pinch, he hardly notices me and he just ignores me. I call him thick-skinned individual. So here individual B cell is like a thick-skinned individual where the cell response is suboptimal and the brain is not able to sense this. So the concept in endocrinology is that we have to challenge this cell and see whether it will respond. That is what is the amplitude and receptor manipulation. So for this we have to have cutoffs. Where do I challenge the cell? Which range I challenge the cell? So we know that, how have we arrived? We know that FSH value, many a times I've seen this. Have you done the hormone? No, doctor, I've done my hormone test. Everything is normal. What is normal? 1.5 to 11. Can there be a range which is 1.5 to 11? Such a big range? Because we have never understood it. Similarly, LH is a very wide range. Which biochemistry test has this kind of a range? Nobody has this kind of a range. So similarly, what we understand now is a normal cell in a given individual. Let's say this is the given individual where I just told you his cell is normal and he is able to produce normal spermatogenesis. What would his FSH level be? His FSH level generally is less than 4. So with a minimal stimulation, the cell will be able to respond. Similarly, LH, with a minimal stimulation less than 4, the cell will be able to respond. So this is the lower end of the spectrum. So we are dividing FSH-LH range, which is based on a kit which is given by the company which markets this kit, not decided by the doctors, and we consider anything between 1.5 to 11 as normal. Here we already know anything above 7.6 is non-obstructive azoospermia. So how does this value matter of 1.5 to 11? FSH above 7.6, men have a very high risk of azoospermia, and most men above 7.6, 88 to 90% of them will start dropping their sperm count and become zero within 6 months. So consequently, we have a high normal. Similarly, LH, we have a high normal. So we have created a range called low normal and high normal. And we know that sperm requires, the third variable which sperm requires for maturity is estradiol, the female hormone, which again has a low normal and a high normal. And this especially, you think that estradiol, traditionally we believe that he has to be an obese individual to have estradiol high. Thin men can have estradiol excess. So on the basis of receptor manipulation, I'm just going back, amplitude and receptor manipulation, if I think of it that way, low normal FSH, what is low normal FSH? Anything less than 4, anything less than 4, LH is anything less than 4, high normal, I have defined that. So low normal FSH alone, that means in a given individual, most of the individual A, I'm going back and forth because I want you to understand this concept. It's a little complex. An individual A with less than 4, that means this individual with less than 4 is able to produce sperm. The stimulation from the brain and putting out FSH is only in the range of 3.2, 3.5 to 4. But an individual B is unable to produce sperm. So here comes the tricky part of this. Though this is a no normal FSH alone, but associated with your pathological sperm or borderline sperm, then you stimulate that axis. You know that FSH axis is stimulated either by clomiphene or HMG, you give him that axis. Similarly, if there is low normal LH alone, you give him HCG. If you have low normal FSH and LH, you give him HMG with a peripheral blockade of anti-estrogens. High normal FSH and LH, they are called dysgenetic testes. They are dysgenetic testes. Medical treatment is futile. Marginal improvement occurs of 10 to 15% with extremely low dose steroids of 2.5 to 5 milligram. Why do we treat them? Only treat them to freeze their sperm, because I want a better quality sperm to freeze, and that's why we treat them. So on this concept, if an FSH is, let's say, 2.2, according to the lab reports, which is normal, but associated with pathological sperm in terms of motility or morphology, what is the drug we give? Either clomiphene 25 milligram alternate day or 2000 units. No, this should be 150 units of HMG twice a week. I'm sorry for that error there. And similarly, if LH is 3.2, you're either giving HCG 5000 units twice a week or tamoxifen 10 milligram, which is a peripheral blockade. T ratio, testosterone divided by estradiol, if more than 10, except in azoospermia, you treat. If less than 10, you give him anastrozole. If both FSH and LH are low, less than 4, then you give him HMG, either 75 or 150 milligram, depending on the body weight. Check semen parameters and hormone levels monthly, because you will see the effect within a month. If they are responding very well, and if their hormone level also correspondingly rises or drops, then you modify the dosage. So that is what is the most important thing which you have to understand. So medical management of infertility is based on an endocrinological principle of understanding that there is a need to look at the endocrine level or the hormonal level, presuming that the two cells which are primarily capable of producing spermatogenesis and assisting in spermatogenesis and spermiogenesis are incapacitated for some reason, and you want to challenge them and see the challenge and see the response. Now, two things will happen. Either the cell will respond and your theory is right and the output may improve. At that point in time, these are cells which are dysfunctional. The response cannot be maintained forever. So you have to quickly do an ART procedure, whatever it may be, or the simplest of the ART procedure to get them a baby, because the response usually comes up to around 4 to 6 months. Beyond 4 to 6 months, again the cell will go into a dysfunctional mode, just like you can't go on giving clomiphene beyond 6 cycles. Similarly, the cell in the endocrinological principle, you can't stimulate the cell continuously. So you need to achieve a pregnancy during that period of time. So, but at the same time, if in the first month you do not see any improvement, then you know these cells are unresponsive. So the challenge will not work, and there you could probably try 1 more month of treatment, and after 2 months, if it doesn't work, you give up the treatment and advise them ART, because medical management is futile. So it's a very clear directed strategy at understanding what are the challenges of male fertility management and driving up that specific area where you want to correct. And of course, you have to maintain, there are 2 groups of patients where you have to be very clear. Obesity in individuals, now we define, especially from a male fertility point of view, anything about 26 as obesity. I know in women it is defined as 28 or 32 or whatever it is, but at the end of the day, there is a need for dietary and other forms of counseling to reduce weight, because spermatogenesis is likely to improve, and we need a BMI, ideal BMI less than 25, but at least 26. So that's what I have put it up here, best below 25 or 26, and this helps in sperm improvement along with your medication. Similarly, sperm in older men. What is older men? Anything above 42. Data on offspring of older fathers, including IQ score, social skill, variety of other health are conflicting, but evidence is emerging of its deleterious effect on the offspring, and it can affect. So consequently, you have to be very careful in these men where you are allowed other advanced testing in the form of DNA fragmentation and so on and so forth. And of course, the third variable is the metabolic syndrome and the sperm, where you have abdominal obesity, you have dyslipidemia, and you have diabetes and other forms of treatment. And what happens in these men? These men have evidence of faulty DNA repair and abnormal recombination, which is your you have your various DNA, leptotene, zygotine, pachytene, and diplotin. So there is this remodeling, which is this one. So consequently, in order to identify, not only are we improving the pathological nature of the sperm from a pathological to a good sperm, but we also need to understand that male gamete competency testing, because it's all about competency. It's just like looking at a oocyte and trying to say, is this oocyte good enough? You grade the oocyte by various methods, morphometric methods and so on and so forth, but still there is an evolution. Similarly, male gamete competency testing has moved tremendously. It is not about just motility morphology, which is like looking at a beautiful man and trying to say he looks tall, handsome, he looks fair, he should be intelligent. At the end of the day, you don't know the intelligence just by looking at men and from their external characteristics. Similarly, DNA got evolved, DNA testing got evolved. Now we are looking at various other forms of tests. I just put this up because these are all important, because when a sperm improves, you want to know what are the characteristics which has improved and to what extent it has improved and what has not improved, because that can direct you whether from a simplistic IUI treatment or from an IVF treatment, and these are all. So to summarize, like I said, I could only take one lecture because I've already finished my 1 hour allotted time. My take home is male infertility clinical management has to be done more effectively on the basis of semen analysis. Semen analysis reports have to be standardized. New report format is the way forward to empower clinicians to manage male infertility effectively based on seminal plasma abnormalities or sperm abnormalities. It also empowers the clinician to take decision on ART strategy depending on the female factor. Monitoring of progress is quantifiable. We have to be answerable to our patients. You can't give them endless therapy and tell them come back after 3 months. which is a disgrace, because at the end of the day, the male is completely fit. He may be a CEO of a company, but we as clinicians sometimes tell him you are unfit to have a child, which is shocking for this couple. Specific management with a structured report and a treatment can be initiated, which is specific and effective, leading to proper ART strategy if it is needed. So this is what it's most important. So the shift in male infertility management is going to happen, and it is already happening. Sperm competency or incompetency assessment, as I would call it. It's not only about sperm competency. I want to know which sperm is incompetent. Sperm selection, sperm presence in tissue, because I want to extract all the sperm in the tissue. Remote diagnosis, identification of fetal risk transmission, a standardization of lab testing and QC sperm transport, because right now you can report whatever you want in your lab and claim that at that point in time when I received the sample, this was the motility. We are kings in the andrology laboratory with no counter verification mechanism. Unlike blood sample, a blood sample can go to 10 labs for a QC and you will be crucified if your report is wrong. Whereas in a semen, you are not crucified. You can always say at that point in time, motility, and that will go. It's a matter of time. We have already released this, and it's a matter of time where we could QC this. Home-based treatment, point-of-care solutions, all these are coming in a very big way. So in summary, a paradigm shift is occurring regarding the cause of male infertility and its treatment associations. Novel structured treatments are being pursued, and incredibly novel stem cell treatments loom in the future, which will empower the clinician to raise the bar. One must show greatest respect towards anything that increases exponentially, no matter how small. And that is what it is. It's like your ChatGPT. Male infertility management is no longer a black box, or it's no longer empirical, because I used to hear this word for many, many months saying that male infertility management is empirical. Thank you very much. I'm open to questions.
Thank you, Dr. Vasan, for those unique insights and covering the subject of male infertility in such exhaustive detail, beginning with the semen analysis and then gradually working up to the different modalities of management available to us. There are some questions in the chat box, sir. You can go ahead and take them. I think one question was about spermatids, if I'm not mistaken. And I think sexual dysfunction is something which you didn't have time to cover. That's a separate lecture by itself. Maybe we will call you back in at another time to have your views on sexual dysfunction as well.
Okay, what is this? There's only one question I can see.
That's about the spermatids.
Yeah. Sir, if there are 90% spermatids in cellular elements in semen analysis, generally spermatids do not come out. I mean, because of at the end of the day, there is a blood test is barrier, and spermatids maturity, very rare to see 90% spermatids in a semen sample. I have not seen one. And so what is the question? Is it normal or is it not always reported? Count is 28 million. Like I said, you only report, like I said, numbers don't make a difference to me. I'm not bothered about the 28 million count, because I told you very clearly, for me, it is like looking at 20 men who are good looking, handsome, and I want a job to be done. I want their intelligence to be tested more than the numbers I have. So numbers are meaningless in fertility management. So it is the quality, just like your oocyte. You can get 14 oocytes, and at the end of the day, if all are GV or if they are not good enough, then you can't guarantee a pregnancy. So similarly, count is of immaterial. So at the end of the day, you need to look at motility and morphology, and that is what is the basic parameter you would want to test, and be clear and precise about it. Sir, you have told some buffer can be added to text. Can you explain? This is our patented buffer where we have created this. You can look up it. It's called Zapneel. It is we have filed. We got the patent also from office, from the Indian Patent Office, and so this is a buffer which you can add where we can send it to the home of the patient. It's not very expensive. I think it costs about 200 rupees for the buffer. You add a 2 ml buffer to the semen sample, and specifically we did this for peripheral towns and villages where the semen analysis was not standardized, and during COVID we did a lot of work and extended. The basic problem with the semen was the motility would deteriorate, morphology not much, motility would deteriorate over a period of time, and we wanted to preserve the motility, and this buffer preserves the motility. The way it works is it's a 2 buffer system where 1 buffer is given to the lab and 1 buffer is given to the patient. Those are 2 separate buffers. So there is a 30% decline in the motility which happens irrespective of over a period of 36 hours. It delays the decline of the motility. It's not that the motility can be maintained the same way, because after all it's an ATP activity, and ATP will burn the sperm to an extent, and that recovery is done by a separate recovery buffer in the laboratory. So it's a 2-buffer system, and we are able to give you a 98% accurate report. And it's the 2-buffer systems are called Zapnil and S-Moti, which is available in the market. If you want, you can message me later. I can send you the details. Sir, many reports we see volume as 1 ml. How do we interpret? Like I said, at the end of the day, if you suspect it's a low volume ejaculate, one of the best ways to interpret this is to ask the patient whether his volume is always low. And patient is always very clear. He will tell you immediately, no sir, I came here because of the environment, I was not able to give a sample. My volume is okay. Because he will know, it's like urine output, right? You will know whether you are passing urine properly or not. So he is the best judge. So if he is able to corroborate as a normal volume, then you take it as a normal volume. If you want to retest it and ask them to bring the sample from home, or give him a sildenafil sample and collect the report, because many of them develop some amount of ejaculatory inhibition in the hospital because of all the women walking around, and some men are very particular about their privacy and the way men also have different ways of masturbation. There are rubbing masturbators, there are bed masturbators, there are wall masturbators. You name the masturbation technique, they will follow it. So some of them are embarrassed by it, and consequently, they might want to hide it. So to answer your question simply, volume abnormality, corroborate with the patient. If he says the volume is good, ignore it. But if you still want to reconfirm, give him a tablet of Penagra, ask him to 50 milligram or 25 milligram, ask him to bring the sample from home and recheck it. That's it. And if the volume, he corroborates the volume is definitely low, then you investigate. Make sure that it's a hypospermia and hypovolemia, and you need to investigate. Role of injection, HCG and HMG. Like I said, I will not go by just because of OAT or whatever you have put there. I will go by, whether it's, of course, obviously it will be pathological when you say severe OAT. I will go by the fact that if there is a chance for me to manipulate endocrinologically, just like I told you, either the FSH axis or the LH axis, I will manipulate. But generally, I won't give irrational treatment just like that HCG, HMG. If the axis to be manipulated, let's say if like I said, if FSH, if there is a severe OAT and FSH is more than 4, there is no role for me to manipulate that FSH axis, right? So similarly, if the LH is also more than 4, there is no role for me to manipulate that axis, because 90% of the time that is good enough. So only in those where the values are a little lower than that, then I will manipulate that axis. If FSH is low, I will give him HMG. If LH is low, I will give him HCG. If both are low, I will give him HMG or recombinant FSH, either way. And additionally, if you want to save the money to the patient, instead of HMG, you can use clomiphene. Instead of HCG, you can use tamoxifen, though tamoxifen acts in a different way, but it's good enough. So these are money saving measures. Not everybody could afford HCG or HMG and especially if you are wanting to choose a recombinant, it becomes very expensive. When will antioxidant become first line of treatment? Antioxidant is never a first line of treatment. Antioxidant is only a co-prescription. It is like, I call it like you are asthenic, you are recovering from this thing. Earlier days, we used to get B complex, neurobion injection and whatnot and what for. So only where it could probably have a primary role is those patients with genital tract infection. Yes, I would put them on an antioxidant because there is a need for the antioxidant because there is oxidative stress because of genital tract infection. That is one indication. But irrationally putting everybody on antioxidant just because some company tells you, who's not even a doctor, who comes and explains to you that your best choice is an antioxidant, is a waste of time. So I would not give an antioxidant to everybody. Genital tract infection specifically, and in those cases with hypogonadotropic hypogonadism, yes, I would give, because there is an element of challenge of the testis with excessive antioxidant activity, and antioxidant might play a role. So drugs used in erectile dysfunction, I don't know whether I'm reading everything, but anyway, whatever I can, I'm just saying. Drugs used in erectile dysfunction, if simply what else can be given? For 2.5 milligram of tadalafil. Tadalafil is a good drug for giving a semen sample. And if at all you are giving tadalafil, it is not that many people, what the mistake they do is they give one drug just before and collect the sample. No, ask him to take it for 3 days. Ask him to come back after 3 days and give the semen sample. Even sildenafil or tadalafil, if sildenafil 50 milligram is causing some side effect in terms of photophobia or headache, he can take a 25 milligram tablet on a daily basis, come on the 3rd day and give the sample. 95% of the time he'll be able to give the sample. Similarly, tadalafil causes an erection for a duration of 30 to 36 hours, and consequently 2.5 milligram is good enough if he is less than 40. But if he is more than 40 or he is a diabetic or a comorbid patient, give him 5 milligram. So that is what it is. Karyotyping, when it is indicated, only indicated at the end of the day if there is a risk of abortion, if there is an abortion in a given individual and you are suspecting the sperm, when you do karyotyping of both individuals. Generally, karyotyping other than that, I have very rarely done, or if there is a risk of abortion in the family and the couple are right in the beginning are very much worried, then you do a karyotyping. But otherwise, I don't see an indication for karyotyping in normal situations. Is there anything else I missed out? Hello? Hello? Hello?
Hello.
Yes?
Ajay, thank you, Dr. Vasan.
Sure. Can I exit? Okay, I'm exiting. I don't know whether I should stay on, but anyway, thank you very much for this opportunity and thank you all. Any of you have any questions, you can always take my number and WhatsApp me, or you're free to call me anytime. Thank you.
Thank you, Dr. Vasan, and we hope to see you again very soon. Thank
Sure.
you, candidates, for logging in, and we will see you again on Wednesday at 4 o'clock. Thank you, everybody. Bye for now.
Bye.